Very good morning to everyone. Respected ASMD ma'am, Joint Secretary RCF ma'am, officers from the states, experts on the panel, dear colleagues from the field, and friends. Thank you for joining us virtually today from all corners of the country. I, Dr. Padmini Kashyap, Assistant Commissioner of Maternal Health, take the honor to welcome you on behalf of Ministry of Health and Family Welfare, Government of India, to this webinar on ensuring maternal health services in COVID-19 pandemic. As we all are witnessing this intense second wave of COVID-19, we have discovered so much about the virus and we are still learning. As the government addresses multiple dimensions of this pandemic, we as maternal health physicians try to do our best in bringing together and imparting the knowledge to our subject matter experts. Before we start off with this webinar, I have a few housekeeping notes to make. You can view us or join us through the link provided, either through the WebEx or through the MOHFW's YouTube channel. If you have any questions during the presentation, please type them into the chat box. We will try our best to address them during the question and answer session. Special attention to the panelists. In order to keep the quality of sound function during the meeting, please mute yourself when you are not sharing. Thank you for your cooperation and attention. May I now invite Dr. Tejaram Sir, Additional Commissioner, Maternal Health and Family Planning, to commence this event by opening remarks and overview of this webinar. Thank you.
Good morning to all the participants of this, esteemed participants of this webinar. I welcome you all to join this webinar. Today's webinar spans over three components. The first section shall focus on the challenges in provision of maternal health services along with guidance provided by the government and vaccination for pregnant and breastfeeding women. The second section largely focuses on clinical management of pregnancy during COVID-19 pandemic, followed by question and answer session. And the third part in this we will bring about experience sharing from the various states in order to impart knowledge sharing and best practices. It is indeed a special privilege and pleasure to welcome Madam Vandana Gulani, Additional Secretary Health and MD/NHM. I request Madam to address the esteemed audience.
First of all, my sincere apologies for delaying this. In fact, I would suggest to my team here that in future such interactions, please do not wait for me to start it. You must start and I can come in when I have time. These are unprecedented, challenging times where we get pulled in different directions. We are working almost in a control room kind of a situation, and therefore sometimes very urgent matters come up and delay these kind of pre-scheduled activities. So for future such interactions, kindly do not wait for me to begin it. You begin and I can come in between and hear you and participate. So this is something I just wanted to flag to my own team here. So very good morning to all the distinguished participants who are gathered today, all our colleagues from the state government who are really at the forefront of managing the situation, colleagues from the districts, experts, healthcare providers, and all the partners who are present here today. We are all gathered here today to discuss a very, very important issue of ensuring maternal health services continuing during the COVID-19 pandemic. And I am aware how difficult it is, especially at the state and the district level, to ensure that you balance both the requirements of the COVID pandemic, whether it is for containment, surveillance type of activities, or for providing treatment, which is increasing in the second wave with huge numbers that we are encountering, or it is to provide the non-COVID essential services, which are very critical to ensure that we are responding to the needs of the citizens in a most citizen-friendly manner, which is important to ensure that the critical services, the non-COVID essential services, especially for pregnant women and children, continue and do not get disrupted. So I am aware that this is a very challenging situation that you are facing, but I would also like to believe in the resilience of our system. And this is something you have all demonstrated last year. And you know, I can share this because I have some early insights into the NFHS 5 data, even for the balanced states beyond the 22 states. And what I'm told is that despite you know, the field work happening last year when COVID was very much around. Probably we do not have too much impact on the RMNCH services. The data is still awaited, but it really goes to speak for the intense efforts that you've all made to make sure that we continue these other essential services also apart from the COVID services. Now, while doing this, I think it is also important, whether we do for COVID or non-COVID, that the protocols are understood by everyone. Uh, the technical protocols, the health system protocols should be clearly understood by everyone down the line so that there is no confusion and we are able to continue to provide these services. I am aware of a lot of efforts by the states. However, if you remember last year, we had come out with two separate guidances. One was for we had issued two guidances. One was for the essential services in terms of organizing the health systems. So use of more teleconsultation, telemedicine platforms, door delivery of contraceptives, sanitary napkins, other requirements that are there, other medicines. We had also given a very clear note on continuation of RMNCH services so that all the essential services continue to be carried on. And those were the days of the lockdown, and despite the lockdown, these services were continued by the states. The other important thing in this would be that we've had continuous engagement with the states after that on the continuance of non-COVID essential services in groups of states. Batch by batch, we did those discussions and reviews, and we had given specific formats to the states to come back to us. And the best part of these interactions was that there was a lot of cross learnings. So there were states which had made sure that the teams for essential non-COVID services are separate from the teams for the COVID services. There were states which have taken specific attempts for made specific initiatives for pregnant women to ensure that each and every pregnant woman is line listed, is given. This was done in Telangana. Each and every woman is given the phone number of the ambulance driver also to contact, that earmark specific hospitals where they would be given institutional delivery. So a lot of such best practices were there from the states which were shared during these interactions. And I think we have to continue this healthy practice because apart from the guidelines that we issue from here, it is really the field action and the practices on the ground and the cross pollination of that is going to make sure that we continuously learn, there is knowledge transfer, and we are able to replicate these best practices. I'd also like to mention in this period the immense contribution of our frontline workers and our health and wellness centers. uh, there was a huge number of footfalls in the health and wellness center, and out of this footfalls, more than 50%, almost 54% were women. So this goes to speak that while the pandemic was raging, these uh, institutions and these elements of health systems which are close to the community saw a huge amount of footfalls, especially from the women, which goes to speak in terms of our vision towards universal healthcare and providing uh, healthcare close to the community. The other thing which witnessed a good practice last year and which needs to continue and get further multiplied is the e-Sanjeevani platform and the teleconsultation and telemedicine. So there were almost 50 lakh consultations during the COVID period. There is half a crore telemedicine consultations which happened last year. And this is something which I think really provides ease to the citizen. It provides them the security that they don't have to visit the healthcare centers, which currently are full of a lot of COVID cases. So this is another thing which I will request all the states to continuously engage, even when it comes to giving the RMNCH services, so that people are not denied these services. So care close to the community through health and wellness center, care in the comfort of their homes through telemedicine. I think these are two things we should continue to focus on. Now, in terms of managing COVID so that it does not impact non-COVID services, as you all know, there has been a huge amount of work that happened through the pandemic last year. Though now the health system is overwhelmed with the number of cases that we are seeing, but a huge amount of investment has happened both from the central government and from the state government. So when I look at the last year trajectory, the three categories of COVID dedicated hospitals, the hospitals increased 23-fold from 163 to 3,000 plus. The health centers increased from 0 to 7,300 odd. the CCCs, huge amount of 40-fold increase in the number of beds. We have 16 lakh beds now. ICUs, we have 1 lakh. We obviously need much more. Lot of HR engaged, especially through the COVID emergency response package, the 8,100 odd crores that we have released to the states and UTs. And I think HR would get further augmented now. And this is another element I would like the states to focus their attention on, is this new dispensation which has been created with the approval of the National Medical Commission, of utilizing the medical interns, of utilizing the final year MBBS students, of utilizing the final year nursing students in the COVID related health work. So if they get, utilized there, we will be able to ensure that there is enough human resource that is available for the other non-COVID services also. So we really urge you to make sure that all such mechanisms are used for human resources, because infrastructure is one part. Unless we have the human resources to manage even these COVID dedicated facilities, we will not be able to ensure that non-COVID services continue to run. The other thing which I would like to point your attention to is very recently on 16th, a new SOP for rural areas and the peri-urban areas for COVID management has been put up on our website. I'll urge you to use this very extensively. It clearly talks about the minimum non-negotiable of ensuring that non-COVID essential services continue while we are providing more and more COVID services also. It speaks about how to manage home isolation, how to engage the frontline workers in monitoring people in home isolation, how to create the dedicated COVID facilities right up to the village level, and utilize various volunteers and human resources for the same. So do have a look at that also. I'm sure you will be able to, with that, balance the requirement for COVID and non-COVID services. So coming to today's interaction, I'm sure there must be a number of plethora of questions in mind, both technical and programmatic as well as health system related, in terms of managing issues related to pregnancy, vaccination, care during ANC, etc. And I'm sure the experts that we have around, not only from the ministry, but several experts that are there from the states and partners, will be able to share their valuable experiences, which can be replicated across the country. There's also this updated guidance and knowledge which would be shared through this discussion today. So my request to all the participants is that kindly make this a very vibrant discussion so that we can learn from each other and make sure that at no cost, while we attend to the pandemic, our core non-COVID health services, especially for women and children, do not get ignored or neglected at any cost. I wish you the very best for these deliberations. And Dr. Sikdar, I look forward to receiving from you gist of the discussions today, and if there are any further actions that we need to take at the Government of India level to support the states and UTs in this endeavor. Thank you.
Thank you, ma'am, for your kind words. It is indeed important for the states to ensure critical services for women, children, and adolescents, and it should be mandatorily provided, irrespective of their COVID status. Each and every pregnancy is to be prioritized. Every opportunity is to be utilized for providing services to the pregnant women if they have already reported at a facility for seeking a particular service, and in no case services should be denied, irrespective of their COVID-19 status. Now, I would request Madam Preeti Pant, Joint Secretary, RCH, to address the audience.
Thank you, Dr. Padmini, and thank you, ma'am, for setting the background of this very important webinar, where we are going to discuss about ensuring continuation of maternal services during the times of COVID. And as we are all aware, that COVID has given us a new normal, and we have to readjust and we have to redesign our services in light of these COVID pandemic around us. So keeping that in mind, we have to also continue our focus on the maternal health services, on continuation of these services. There are challenges, if you see on the field, on account of how to provide these services by maintaining the COVID appropriate behavior, by giving the adequate protective gears to our workers. So, so keeping that in mind, it is very important that we have a discussion and we share our thoughts around this important area. And moreover, now as we are seeing it, that the pandemic is moving from the urban setup towards the rural setup, and ASNMD has just now pointed us that the guidelines have also been shared. So those guidelines will give a go ahead and what should be done and what is required to be done. So despite all these challenges, as we are aware that services are to be provided closer to the communities, we have to involve the communities, and we have to ensure that all these services that are being available in the normal times, which includes not only your antenatal checkups, but also ensuring deliveries, ensuring that the skilled delivery is made available. And apart from that, the postnatal services are also made available to all the women. And besides that, we have to see that the health workers are also taken care of. They are provided with the necessary protective equipments, and we have to see that the infection control measures are in place. And besides, the ASHAs and ANMs and are able to reach the women. So there is a whole lot of things that we have to keep in mind, that we have to focus upon, so that despite the new normal, the provision of services, the continuation of services goes on, and we are not falling short. And as it was also shared by ASNMD, that the early trends of the remaining NFHs are also indicating continuation of our services. So, so keeping that in mind, it is important that we continue all our services. And as state program managers and as state officers, it's very important that we continue to guide. We are available here. Our team, led by Dr. Sigdat, is available if there is any guidance required. So we have a whole detailed presentation that is to be made on this subject, that what are the challenges that are there, and what are how do we need to address those challenges. So in midst of all this, we are also hearing that the services are being provided. Our HWCs are being utilized not only for COVID services, but also continuation of other services through the telemedicine. So, so I would request Dr. Sigdat to please share with us the detailed presentation, and all the participants from the states are requested to come up with the field experiences, what they're having, what are the actual challenges they want to share, what are the things that they need to tell us, which needs to be facilitated from here, so that we can respond and recalibrate our responses. So with that, I would wish a very productive seminar. And Dr. Sigdat, I hand over to you. Thank you.
Thank you, ma'am. Thank you, Dr. ASMP ma'am and JS ma'am, for their unstinted support in this time of calamity and issues that we are facing across the country, as we get these messages from all over the states that there are challenges that we are facing. So before I just go through this presentation regarding the challenges, I would rather just summarize what was said by ASNMD. A very clear direction that whatever is the this thing, sort of assessment of today's meeting, at the end of the day, we will compile the requirements or the demands and the suggestions from the states. And if in any way the government of India can come up with guidelines or directions which can really ease matters for your states to really provide the services without interruptions, is something that we're going to welcome. So please be free to give your suggestions on the chat box. We will try to address some of the questions which may be relevant to all the states of the country during the question answer session. But other than that, you're all free to really come out with suggestions in the chat box. That is one sort of a activity which we want to accomplish by the end of this evening, so that we can really, so that this particular day of the webinar really becomes productive for the whole country. Having said that, now I'll take you through the challenges in providing mental health services during this pandemic, and let me be very upfront that these challenges are something which we have not identified alone over here from the national level. We have had discussions with all the states of the country, and from there, we have accumulated these challenges. And what we have done, we have these challenges on one side. What are the probable causes, and also the solutions to the best of our knowledge, how we can provide the solutions to those challenges to the extent possible. So that is the way that we have been able to accumulate these challenges. Next. So before we move on to the challenges per se, on the introductory front, about the COVID-19 status in the country. You can see the second wave, the rampaging second wave, how the numbers went up, and now fortunately the numbers are coming down to around 2.5 lakhs from 4 lakhs in a period of around 3 to 4 days only. That is something very positive. We are still not getting much clarity on the urban and rural divide, because the not specified part is the major part, is around 58%, and the rural part is showing 12.4%, and the urban is around 29.6%. But our hunch is that the truth is somewhere else, because now that the urban areas are showing a little bit of plateauing, it is something the rural areas, the hinterlands, where the numbers will probably go up in the next few weeks. And we have to be very careful, because most of the services that we provide are at the field level, the peripheral level, where the issue of this COVID-19 will now come up front. And that we have to be ready to really address those issues before. So for that, we need to educate it on the issues that can come up and how to manage those. And this today's meeting is a step from the government of India to enlighten you on the various aspects of pregnancy with COVID. Next, just one or two data, its impact on the maternal health services and on COVID. Now, this is a data which we have compiled from the HMIs, and here you can see that there has been a huge decline in pregnant women registered for ANC, especially in the states of UP, Bihar, there that we are looking at. Whereas there are states like Andhra, Himachal, JNP, and Punjab, where the numbers have actually improved, which is a very positive thing. But the decline that we are getting from the states like UP, Bihar is very, very high, to the tune of 6 and 7 lakhs decline in antenatal registration in states like UP, and also around 2.5 lakhs in Bihar. So these are something that we need to look into very seriously. Similarly, the differences in the number of first-time registrations, you see again the states of UP and Bihar stand out in terms of the numbers that they are able to register. So there is a huge lacuning, whereas the states like Andhra Pradesh and Madhya Pradesh have done better than the other states in terms of actually increasing over this last 1 year period. Then also on the institutional delivery, you see, coming to the next slide, here again we see there has been decline in many states, and in fact hardly any state has shown an increase. And also, if you really compare it against the home deliveries in the lower bar, you will see in the home deliveries, Uttar Pradesh has shown a decline of 1 lakh home deliveries, and Bihar has shown a decline of 36,000 home deliveries. And this is something which is not believable, for the simple reason is that whereas the institutional deliveries have gone down, the home deliveries too have gone down. This is basically a case of the missing deliveries. And probably you need to have a sort of an initiative from your state level to see that where are those missing deliveries. This cannot happen. There has to be some sort of a logic behind it. So my request is probably the state should really pour into this area of the missing deliveries, or probably carry out some immediately, pilots cross-sectional studies to find out what are the real reasons. It's not. It could be issues of data entry also. So that is something that the state has to look into. Now, next, these are the factors which are affecting the use of essential health services during this COVID pandemic, and they are broadly divided into two areas: the demand for services, the demand side one, and the supply side one. On the demand side, all of us know that there's a movement restriction, so people are not able to access services, and there is a lost income. Many of the people have lost their employment, jobs, and also the money that is they are having in hand to really take advantage to access the services, and also concerns about the COVID transmission. They're afraid that if they travel too much, they will probably contract the COVID infection. That's the reason why they are not accessing services. On the supply side, we have the issue of many of the health facilities getting converted into COVID care facilities. Now, that is the reality on the ground. So that what happens is that for maternal health services, especially delivery services, then the beds get limited. So that is an area where every state is fighting. Some of the states have done well, some of the states have not done as well. Similarly, for redeployment of the staff. So many of the staff who are employed in the RMNCH arena have been moved to the COVID arena. So what is happening that the RMNCH services has really suffered a little bit. That is something that we have to look into. Another is the supply chain. Now, this also, because of any pandemic like this one, we also are encountering certain supply chain issues also. So these are the factors. Coming to the impact, the next slide. So globally, if you see the Lancet study quotes that the maternal and fetal outcomes worsened during the pandemic with increase in maternal deaths, stillbirth, ruptured ectopic pregnancies, and maternal depression. So this is something that has happened over the last year and is really brought out by the Lancet studies. And to ensure the community services, as was mentioned by the ASMD in our inaugural address, that we had come out with two directives on the 14th of April, to be precise, and the 24th of May, outlining the services to be provided without denial to a client, irrespective of the COVID status. And this is something by and large remains the same. We are thinking what additional guidance can be given, but we believe at this point these are quite good enough guidance. But as I said, if we get really other suggestions from the state, which is workable and feasible, then probably we will add those things also in a fresh guideline, which we can then bring out very shortly in the near future. Coming to the challenges per se, here is the list of challenges next. What we have done, we have accumulated all the challenges that we have been able to find out from across the country and from across by talking to different states and also the experiences that we have. So we have lined up there on the left-hand side. In the middle, we have given the causes and the solutions on the right-hand side. So number one, pregnancy is a vulnerable state. It's known to all of us. And what are the causes? Because more pregnant women are getting affected. It's not because of the percentage wise may not be getting affected, but since the numbers are huge, so in absolute numbers, they're getting affected more. Then the virulence strain. This particular strain we have found in the second phase is a little bit more virulent and also more transmissive, and it is really multiplying fast. And then the prolonged illness. So these are the causes, and then solutions that what the states are doing and should do is early screening, triaging, and admission. This is a non-negotiable sort of a thing. Elaborating on the early warning signs, and this is something which we'll cover in the next presentation in our standard operating protocol sessions, and the teleconsultation services, which has become ubiquitous across the country. State after state have come out with their own helplines, specifically for pregnant women also. So these are some things where we are able to address the challenges. Next is about the shortfall of healthcare staff in labor rooms and maternity OTs. And this shortfall is not something which is artificial. This is something which has happened in spite of the available sanctions trade. The reasons have been given: either they are getting infected, majorly what has happened in the second phase, or they are diverted to COVID duties. Many of the RMNCH staff that we had have been given additional work as COVID duties, and then some are on leave and some have become demotivated because of this raging pandemic. So the solutions for that, what ASMD mentioned, that we have come out with the latest order about augmenting the HR for including the medical interns as well as the first final year students. That is going to add to the pool of service providers. Then reinforcement of the infection prevention and control methods to minimize the infection. Also adhering to self-protective equipment, refresher sessions of all self-protection protocols. This is something what happens is along the way, because as the COVID numbers are waning, people took it very lightly, and that's one of the reasons why it came back with a resurgence. And then self-delivery application, what we are having in with us, we have made a separate module for infection prevention protocol for pregnant women and psychological counseling. Now, we mentioned one of the causes of demotivation. So psychological counseling is one area where we are putting a lot of money on, and it's through our community health officers system. This is one area where we are looking into. You will have a presentation on this today, which will really outline very simple words what you can do in the field level to counter these counseling issues, both for the clients as well as for the providers. Next. Coming to the gaps in knowledge and training and management of COVID-19, and what we have seen is that there's a plethora of knowledge in the country. Everybody seems to have become an expert, and problem arises when there's confusion everywhere because there is lack of clarity of management protocols. Also, the confidence level also kept in such sort of a situation. So, our solution is that we are management protocols being discussed in today's webinar. So, we have selected certain topics after a thorough analysis of the areas which needs really strengthening. So we have lined them up. These are actually the sessions that are going to be carried out today, and also states to conduct the virtual refresh sessions and webinars for capacity building. Just as we are conducting, I believe many of you are already conducting these sessions in your states. Maybe even these capsules that we are going to give to you, you can use this capsule for having this sort of refresher sessions across your state, across your districts, to really bring everybody on par with the clinical management protocols. Next. About the oxygen has been talked about very widely because this is one area where in the first wave we didn't feel as much need, but this new strain as well as is actually showing that they hit the lungs very fast. And also the depletion of the oxygen is one area what has come out very strongly in the second phase. And also health facilities because of this is getting really overwhelmed, and we hardly have beds to cater to each and every patient who are really approaching us because the capacity of the health systems have been ramped up, but all said and done, it is not easy to ramp them up overnight. It takes time for to really provide all the necessary and quality services. So the solution is that we are dealing with this oxygen issue at the very highest level. Almost every other day there is this presence of this particular issue. Oxygen clients being set up, and the states with central support. Oxygen express coaches have started. Oxygen concentrators from the domestic supplies as well as those which have been imported have been supplied to the states. So we believe that the situation should ease out in the next 2 to 3 weeks. Next is about the disruption of the PHMD sessions and PMSFA services. And this is something has really affected us in a very big way, especially from the maternal health and other RCH perspective, because this window we had the PHMD sessions is one where it's all about women coming and accessing or getting consultations. And that has resulted in reduced ANC footfall. Also a fear complex around COVID, which is really prohibiting the clients to go to centers like an Anganwadi center or a sub-center to get immediate support. So that's the reason why we have come out with this teleconsultation scheme through the e-Sanjeevani, which explains the danger signs of pregnancy through the telecommunication. Also, in some states, they have come out with the training the gynecologist also for obstetric specific guidance that they can give through the telephone. And this is already some of the states, and probably one of the presentations will talk about it. And then there's a Kilkareen app. So we are now customizing the Kilkareen app for devising specialized messages to deal with this issue. Next. Coming to the increase in the unnecessary referrals. So this has also happened because health facilities have been converted to COVID centers. Staff shortfall, which we mentioned earlier. Space constraint is one practical problem that state after state they provide are coming up with because they can't really convert an existing labor room into immediately a 2-room labor room by bifurcating them or whatever. So this is something is what is being taken up by the states. Some of the states have done well, some have not done as well. Ideally, there should be separate labor rooms, septic labor rooms for the COVID clients to deliver. Also, another reasons why the private facilities have been hesitant to admit COVID-affected pregnant women. It came out very prominently in the first phase where they were hardly accepting any cases, but now in this phase, probably it has a little bit slowed down, but otherwise also this issue still remains. Nobody is a big people are the private hospitals are afraid to admit COVID affected pregnant women. So for solution's sake, what we are saying, we need to have earmark facilities for RCS services for COVID and non-COVID pregnant women. These had come on the guidance note which we had provided last year. Referral in time with tagging of facilities for a chosen block or villages. We can follow the Tamil Nadu model or the Telangana model, which ASMP have talked about, that even they are tagging the drivers to a particular pregnant woman, so that whenever the need is there, they don't have to run around from pillar to post. Just call the driver who will come and pick you up and take you to the facility. So that those sort of things have been done at the state level. Then phased engagement of the PMJ and panel private hospital. Now, this is one opportunity available that through the PMJ, you can empanel the private hospital for provision of this service. As a letter was already gone last year. This you can activate. Next. There is a suspected increase in home deliveries. Now, as I was mentioning through the data, that many other states like West Bengal or Rajasthan had shown increase in the home deliveries. That is in some places it has actually happened. In some places, probably the data is not reflecting it because people are reluctant to visit for institutional deliveries and they are resorting to train birth evidence for home deliveries. This is happening in some of the states. Also, the overburdened 102 ambulances, because the number of cases is increasing, they are not able to cater, so people are left to fend for themselves. So that's the reason why this increase of home deliveries might have happened. The solution is more and more awareness on this arena, what the government is doing, what the state governments are doing, track the pregnant nearing the TDD, empowering the SPI, the skilled birth attendants to provide home delivery services so that in case somebody asks them to provide the services at home, our ANM can go to the residences of the pregnant women and provide the services there to provide to avoid getting infection from multiple sources in the hospital. Then birth preparedness of all mothers in the third trimester, whether it is non-COVID, the nearest delivery point. So this is something, again, this is all about planning and meticulous planning at the peripheral level. Then COVID positive, dedicated COVID FRU. We had mentioned in the guideline, many of the states have done it, but they had probably relaxed a little bit. Now probably we have to make it a sort of a permanent feature for us to have this COVID sort of a pandemic dedicated FRU for times to come. Next. So limited COVID testing facilities. This is also one issue which we have come across, especially in the field areas, in the far-flung rural areas. One could be the shortage of testing kits, another could be the delayed reporting. Solutions line is that lies the fact that many labs are not conducting RAT tests during trial and managed. So the RAT may be allowed at all available government and private healthcare facilities and set up a dedicated RNG booths in cities, towns, and villages to offer this testing. And testing booths may be set up at multiple locations. These are part of the new guidance, but the link has been given over here. Is something that has come out, and states are requested to take it up in a mission mode so that the number of testings can really increase big time. Next. So coming to the fear of acquiring COVID, this is something, there is also an ill-perceived notion, considering that the service providers, like the healthcare workers, like the ASHA, ANMs, or doctors are super spreaders. This had gained a lot of ground last year. Fortunately, may not be as strong this phase, but it was very strong in the last phase, where people were afraid to even talk to or meet the healthcare providers. So for that, we need to really have the information, education, communication campaigns, and also the best is to follow the COVID appropriate behavior, on which we relaxed a little bit, a lot in the last phase before the second phase came in. Next. So another challenge is reluctance to follow the COVID appropriate behavior, as I mentioned. So we must see to it that come what may, at least for the next 2 to 3 years, we stick to this appropriate behavior very, very religiously. Unless we do that, we will not be able to break the chain of transmission, and we probably will be back to square one. So some of the steps that we have mentioned, for reducing the risk of coronavirus, these are routine ones: using mask, hand washing, having distance, not coughing. So those sort of things are there. Next. So the conclusion: the COVID-19 presents an immediate and emergency challenge to the healthcare system. However, it should be ensured that provisioning of safe maternal health services to women is not impaired during this period, in spite of their COVID status. Because we have mentioned that under no circumstances should there be a denial of services, irrespective of the COVID status. whoever is approached a particular facility should not be turned away. They should be provided services. Of course, the service provider should take all the precautions, the PPE and personal protection equipment should be in place, but the denial should not be there. Next. That's about all for this presentation, and thank you very much for your patient hearing. And we will be, as I said, soliciting suggestions from the states and from the participants, which we will then accumulate and come out with some sort of this thing, compendium, and take them and respond to them to the extent possible. I now request my colleague Dr. Padmini to deliver a lecture on the standard operating procedures. Padmini, the floor is over to you. Please come and you can have it from here.
The essential maternal health services SOPs during COVID-19 pandemic. So on 30th January 2020, as we all know, when the first case of COVID-19 was reported from India, the whole of the government machinery responded promptly. The country adopted a proactive and rated response for fighting the pandemic, which manifested not only in the form of imposing a timely lockdown, but also gearing up of all the health system, boosting of production of necessary medicines, as well as supplies, as well as capitalizing the large-scale behavioral change. Simultaneously, the ministry issued guidelines on 14th of April 2020, enabling delivery of essential health services during the COVID-19 outbreak, which highlighted that essential services for all areas such as RN&CHA, prevention and management of communicable diseases, treatment of chronic diseases to avoid complications and addressing the emergencies have to be continued, so as to minimize any morbidity, increase in morbidity or mortality due to other conditions. Subsequently, guidance note was also released on 24th of May 2020, which elaborated that various RN&CHA services are to be provided irrespective of the COVID status of a pregnant woman who is arriving at the health center. And the area, obviously, this categorization, this was as per the categorization of the areas into contamination zones, the buffer zones, and the other areas. Now I'll take you through the latest updates this year as we are beginning this second wave of COVID-19 pandemic. What's new? What all advisories or guidelines have been released by the DOI? So this on 25th of April 2021, a new advisory was issued to all the states and union territories. This talked about the new containment strategies which is being implemented now. This reiterated on this five-fold strategy of treating, tracking, isolating, testing, tracking, isolating, treating, and vaccinating the COVID affected patients. Also, delineation was made of the geographical areas, and new criteria was set up for categorizing an area as a containment zone. This criteria or the parameters was if an area has a test positivity of 10% or more within a week, or the bed occupancy rate is more than 60% of either the oxygen supported or the ICU beds for more than a week. Once identified, these delineated geographical areas required a strategic implementation of intensive measures focusing on contamination, containment, testing, surveillance, clinical management, vaccination, and community engagement. So these local containment measures are based on the virus transmission dynamics and follow the principle of epidemiology, and it focuses on restricting the intermingling of people so as to prevent the virus chain of transmission. Yeah, the containment focuses on it basically aims at flattening the curve of epidemic by imposing night curfews, restrictions on gatherings, public transport has been curtailed to a maximum limit of 50%, but the essential services are to be continued, and the healthcare workers, the frontline workers, barring these, there are restrictions which have been imposed. As far as the testing and surveillance is concerned, edited testing and door-to-door testing and case searching using RAT or RT-PCR has to be carried out with the help of teams which have been formed, and also there has to be a compliance of COVID appropriate behavior. As far as clinical management is concerned, there has to be an effective monitoring of home isolated patients, ensuring regular supply of home isolation kits and regular visits of surveillance teams for regular monitoring of these home isolated patients. Also, it includes analyzing and upgrading the health infrastructure and plan for logistics as per the phase growth trajectory, depending on the spread of the virus. Seamless hospital admission process has to be ensured as per the symptom of the patient. 100% vaccination for eligible age groups is one of the criteria, one of the focus of this new strategy. Community engagement in order to promote COVID appropriate behavior as well as avoiding misinformation and panic in the community. ICMR released new COVID testing guidelines on 4th of May 2021, and it says that RT-PCR tests must not be repeated in any individual who is tested positive once either by RAT or RT-PCR. Also, no testing is required for COVID-19 recovered patients at the time of hospital discharge in accordance with the new discharge policy of MHFW. Although no RT-PCR test is required for interstate travel, but symptomatic individuals should essentially avoid traveling. During the current upsurge of COVID-19 cases, any individual who is presenting with any upper respiratory tract infections, any influenza-like illness, is considered to be a suspected case of COVID-19 unless proven otherwise by confirmation of another etiology. So this time it includes gastrointestinal symptoms also. The patient may also have bouts of diarrhea, fatigue, vomiting, etc. Going further, on 8th May 2021, national policy for admission of COVID patients in hospitals was revised to be more patient-centric. It was decided that positive test for COVID-19 virus is not mandatory for admission to a COVID health facility. And no patient will be refused services on any count. These services may include medications, provision of medications such as oxygen or essential drugs, even if the patient belongs to a different city. Also, no patient shall be refused admission on the ground that he or she is not able to produce a valid ID card, a valid identity card, which does not belong to that particular city where the hospital is located. Admission to hospital must be need-based and strictly in accordance with the revised. Also, the discharge should be in accordance with the discharge policy of the Government of India. Then, very recently, on 15th of May, SOPs were released for containment measures in peri-urban, rural, and tribal areas. As we are seeing that there is an upsurge and a rapid rise in the number of cases in our rural, semi-urban, and rural areas, which was not there in the previous wave. So the active surveillance for influenza-like illness or severe acute respiratory illness has to be done periodically by ASHAs with the help of VHMD committee members. Symptomatic cases have to be triaged at village level by teleconsultation with community health officer. Those cases found with significant comorbidities or deterioration of clinical symptoms should be sent to the higher center. CHOs and ENM should be trained in performing the RAT testing, and provision of RAT kits should be made till the sub-center level, the health and wellness center level, PHC levels. Every sub-center should run an ILI or SARI OPD for a dedicated time slot or days. A home isolation kit shall be provided to all such cases. Also, the provision of pulse oximeter and thermometer should be there at the village level in adequate numbers. Coming to the essential RMNCH services. RMNCH services, as we all know, they provide a continuum of care and they form the core of NHM, including the antenatal, intranatal, postnatal care services, management of sick newborn, immunization and child care, family planning, comprehensive abortion care services, as well as adolescent health. Coming to the guiding principles, as we all know, the advisory was released by the ministry last year, which said that under no circumstances there should be any denial of essential services for pregnant women. Every opportunity is to be utilized for providing services, even if they have already reported at a facility for seeking a particular service. It should not be denied irrespective of their COVID status. So, while we are dealing with the pregnant women at a facility, I would like to elaborate on the guiding principles for the healthcare workers as well as the facilities where delivery services and the essential RMNCH services are being provided. So the birth preparedness needs to be ensured. Designated a dedicated fleet of ambulance for pregnant women should be designated. 102 GS5 ambulances should only be used for transporting pregnant women and sick infants. There should be mapping mechanism for lateral referral linkages. Triage room should be created for the pregnant women to be screened for any COVID-like symptoms. The latest testing criteria notified by ICMR must be followed. Also, all pregnant women, irrespective of their COVID status, should have access to women-centered, respectful, skilled care. The delivery services have to be continued to be provided in all the facilities. All delivery points are advised to have isolation areas and preferably a separate labor room and OT for pregnant women who are suspected to have COVID infection or who do have COVID infection. Also, a provision of separate labor room and OT is preferable, and if available, it may be utilized for conducting delivery for these COVID patients. Normal vaginal delivery is the safest mode of delivery in a patient infected with COVID-19. Assisted delivery if required to cut down the second stage of labor in case of any obstetric indication. Also, cesarean section is to be done only when there is an obstetric indication. As I said, we have to ensure that there is no denial of services to the COVID affected pregnant female. Also, the blood storage units and the blood banks have to be kept functional. Coming to the triaging part, so any seeking healthcare services shall be screened at the triaging facility, area of the health facility, so as to minimize the contact between a suspected COVID-19 and non-COVID-19 patient or the pregnant female at the health facility. So, what is a triaging area? A triaging area is a separate spacious area near the entry of a hospital or particular health facility, which is utilized for screening a pregnant woman when she arrives to the emergency with either any symptoms of labor or any other complaint before she enters into the main labor room. So a triaging area before a woman when she undergoes a triaging, if she is screened negative, she can be managed as a routine pregnant woman, and if she is COVID suspect, she can be isolated in an earmarked area, and her samples can be sent for testing. If she is in imminent labor, we have to ensure that she undergoes delivery in the same facility. Even if the patient comes out to be COVID positive, if she is not in labor, she should preferably be referred to a COVID health center or a hospital, depending on the severity of the disease. However, if she is in imminent labor, she has to be delivered in the same facility, preferably in a septic labor room with all the universal precautions, infection prevention protocols in place. Coming to the labor room and OT preparedness, it is to be ensured to have sufficient supplies of all personal protective equipments and hand washing facilities in all the labor rooms and OTs. All universal precautions and infection prevention protocols have to be followed, including disinfection of the surfaces with sodium hypochlorite solution. The number of visitors in the labor room should be restricted, which includes the birth companion also in the labor room as well as wards. The number of staff in the operation theatre should be kept to a minimum, and all of them should wear appropriate personal protective equipment. The PPEs have to be worn. Allow time for a full post-operative theatre cleaning. This is very important. The healthcare worker should be trained for the use of PPE so that emergency theatres are functional round the clock. The staff should follow regular hand hygiene practices, hand washing before and after examining every patient, also wearing of sterile gloves for examining the patient. I'll quickly touch upon the principles of clinical management, although this will be dealt with in details in a separate later presentation. So, for a COVID-19 positive pregnant woman, if she has developed mild symptoms or she is pre-symptomatic or asymptomatic, she is not in labor, home isolation is the preferred strategy. As per the revised home isolation guidelines updated on 5th of May 2021, if there is non-availability of isolation facilities at home, she can be very well taken up at a COVID care center. However, if this lady, she goes on to develop moderate symptoms, or in the at presentation only she had moderate or severe symptoms of COVID, she will require admission in a dedicated COVID health center or a district COVID hospital as per the symptom. states may decide to home quarantine or home isolate those pregnant women who fall under the criteria mentioned in the home isolation and home quarantine guidelines. Also, the frontline worker, the healthcare worker should prime the pregnant women about the danger signs of pregnancy as well as the worsening of the signs and symptoms of COVID-19. So immediate medical attention must be sought if serious signs or symptoms develop. As mentioned in the home isolation guidelines or danger signs of pregnancy develop, in such cases, pregnant women should be referred to an appropriate FRU. So in case of COVID-19, the symptoms which have to be looked after are difficulty in breathing, difficult oxygen saturation, whether SpO2 falls below 94%, persistent pain or pressure in the chest, mental confusion or inability to arouse. So these will be dealt with in later expert panel discussion. On the right hand side, we have displayed the danger signs during pregnancy, which you all are aware of. Coming to the referral policy. So, birth preparedness and complication readiness plan, especially for pregnant women in the last semester of pregnancy who are nearing their ETD, and for SOS calls, this is the key to success. There is a requirement for mapping of referral and referring facilities, and one person should be made accountable for. One person should be responsible for all the referrals which are taking place from a particular facility. A responsible person, preferably nursing in charge of the labor room or OT. Also, this has to be ensured that complete case reports are sent to the patient along with the reason for referral while she is being transferred to avoid any issues with the patient during the acceptance at the referring center, at the other center. Prior to referring, the facility should telephonically contact the referral facility and confirm the availability of resources for management of pregnant women with COVID-19. A very good practice which I saw in some of the states which are listed was that there was a formation of WhatsApp group, including officials from all the level of facilities, the state level officials, the district level as well as block level officials were there. They were a part of this WhatsApp group, and any patient which is being with the requisite details, the details are actually put on this WhatsApp group, and the communication basically it's a two-way transparent communication so that the patient doesn't have to undergo any issues during the process of transfer or during the process of acceptance at the other facility. So this is a very good thing which can very well be taken up by other states also. Coming to the ambulance services. So, even for the ambulance services, we have a well laid out plan for COVID affected pregnant women. So, when a call is received at the call center is supposed to triage the case based on the few questions, which includes whether the patient is actually a suspected case of COVID-19, and if yes, then what is the seriousness of the condition? What is the clinical condition like? Whether is she amenable to transfer? Is she stable or is she in a critical condition? As well as the demographic details of the patient. So, on the basis of this information, accordingly, either the 102 Janani Express, which is the normal mode of transport for pregnant women and sick infants, may be provided to the patient. Or if she is suspected of COVID, then a COVID ambulance, depending on her situation, a basic life support or an advanced life support ambulance has to be provided to the women. So all these guidelines, these advisories have been updated on the ministry's website, and they can very well be accessed there. So with this, I come to the end of my presentation, and we'll move on to the next part, that is about vaccination in pregnant women in India. So lately, we have been inundated with multiple questions regarding COVID-19 vaccination in pregnancy and lactating mother. So our next presentation will be on vaccination against COVID-19, and I invite Dr. Sikra sir to please give a presentation on vaccination in pregnant women.
So thank you, Dr. Padmini, for that elaborate account of the SOPs. Some of you, most of it, you probably knew it. It's sort of a reiteration for all of you. So, so that is one area where we actually cannot really get away from the SOPs. That is going to save us in many of the tricky situations. As she mentioned about the vaccination part, It's a tricky question, and we have been inundated, so to say, by request to start vaccination for pregnancy in India. So ministry has not been sitting on it. Ministry has been working on it over the last 1 month and have been taking inputs from different experts and different associations. So I'll just put in front of you what is the current situations and what are the pros and what are the cons of the vaccination program or the intended vaccination for pregnancy in India, and then let you know that where we stand as of now. So coming to this, that the DCGI has approved the 3 vaccines in India, Covishield, Covaxin, as well as Sputnik 5 for restricted use in emergency in the country. That is already known to everybody. But there is also a letter from the government of India itself, especially on I think the 14th of January, where we mentioned that this year itself, the pregnancy and lactation is the contraindication for both these vaccines at present, and they are not part of any COVID-19 vaccine because they have not been part. The pregnant women have not been part of any COVID-19 vaccination trial so far. So that is the situation as per the letter given sent by the state government, by the national government to all over the country. So and as we said that after this, actually, we didn't have many requests from the different agencies and the states on this or the clarity they were not asking us for. So as I said, now we are getting many requests. Next. Coming to the product insert element, what do the product manufacturers talk about as far as the Covishield and the Covaxin vaccines are concerned? These product inserts are very categorical. In fact, both they speak the same, although in a different language. What they're saying is that since it's not been tested on pregnant women, either of this vaccine, there is not enough data. In fact, no data, to be precise, on these 2 vaccines. It should not be given to the pregnant and lactating women. That is the stand by the manufacturers. Next. On the other hand, we are aware of certain studies, recent studies which have been carried out across the globe, carried out in the US. They have been published, and that's only on the use of the mRNA vaccines. For your information, the vaccines available in India are not mRNA vaccines. So this basically pertain to Pfizer and Moderna. So these are the 2 which have been studied. And here there are 2 studies, study 1 and study 2. On study 1, there have been a subject of 131 subjects, of which 84 were pregnant women and 31 were lactating. And here, what we found, the study, or rather the study found, that the vaccine generated robust humoral immunity in pregnant and lactating women. And also, vaccine-induced immune responses were significantly greater than the response to the natural infection. And thirdly, the immune transfer to neonates occurred via placenta and breast milk. Now, these are very strong findings. Again, but the sample size was very limited. So probably it's something that it's still in the study stage. Coming to the second study, where the numbers were pretty high, around 35,000 were taken. And here we find that the findings which has come out is that the vaccines did not show any obvious safety concerns with respect to pregnancy or outcomes. So it's a language, a little bit of diplomatic. They did not show any obvious safety concerns. Means probably these can be given indirectly. It is inferring without saying it in as many words. Next. Coming to these are the position statements of the professional body in our country as well as abroad. Now, these are very respected professional organizations across the world, and that is something on which there are a lot of credence is attached to these organizations. So whether it is FIGO, the International Federation of Gynae, the American College of Gynae, the Royal College of Gynae, and as well as our own homegrown FOXY. So the tenor of all this that we find is that they support offering COVID-19 vaccination in pregnant and breastfeeding women in different languages that they have mentioned. So I'm not going through each of the findings that each of the recommendations that they've given. Suffice it to say, they are saying that probably we must give the vaccines to the pregnant women and lactating women. Next, the WHO statement is also favorable. Use of AstraZeneca's COVID-19 vaccine in pregnant women only if the benefits of vaccination to the pregnant women outweigh the potential risk. Now, this becomes problematic because it's a statement, but it is really not backed by any data. That being the case, it becomes difficult for many governments to really come to some sort of conclusion, because at the end of the day, when you are coming out with a policy of vaccinating pregnant women, even one casualty can become a calamity. So we have got reports that this probably the AstraZeneca vaccine was given in Brazil, because in Brazil a lot of women were supposed to be dying because of contracting COVID-19. So they started vaccinating with the AstraZeneca vaccine, the Covishield vaccine, and here one case was reported where the pregnant woman is supposed to have died. So the details are awaited. So these are against the backdrop of this, it becomes difficult really to take any decision next. So these are the conclusions that we have. The data is very limited on the use of COVID vaccines in pregnancy. The only published data was available for mRNA vaccine in pregnant and lactating group, and both are being administered in India, and both are non-mRNA vaccine. That being the case, what we have done from the ministry, as we have said that we have not been sitting idle, we have been very proactive. We moved it for opinion of the technical body. So there is a standing technical subcommittee which is there in the Ministry for Immunization, which reports to the National Technical Advisory Group on Immunization. So that they have delivered on this pregnant woman to be offered the choice to take any COVID-19 vaccine as well as the lactating women who can be inoculated. But right now we haven't got a clear direction. We have been told that this matter probably has gone to the apex body, the NTAGI, and the decision is awaited. There may be some positive movement on the lactating women part, but as I said, without an advisory, we can't be sure. But we are awaiting the decision of this high-powered technical committee of the government, which actually controls the introduction of any vaccine or the modality of any vaccine in India. So that being the case, situation as of now, it stands is that we have no approval for vaccination for pregnant and lactating mother as of now. Whenever it is available, we will be communicating to all of you very, very promptly without wasting any time. So thank you very much for this particular presentation. So what we can do right now is that we are already 1 hour behind schedule. And for that, of course, it is one reason could be that one reason was there was serious technical glitches because of internet issues, hosting and co-hosting. That being the case, it took a lot of time to get resolved. Otherwise, we know many of you were actually hooked on since 10 o'clock in the morning. So we really beg your pardon for that, for the delay. So what we will do, we'll take only a 5-minute break right now and immediately move to the technical part of the presentation, which will be very, very important presentations. So we won't waste any more time. We are switching off for 5 minutes, and after 5 minutes, we will reassemble for all of you to be there. So you may remain connected. In just 3 to 5 minutes, we will start our next round of presentation. Thank you very much for a patient listening from the ministry side.
I welcome you to the second technical session of today, which is on the clinical management of COVID-19 pregnancy. Since we are running a little short on time, I will take the privilege to introduce our first speaker for this session, Dr. Anushri Patil, who is Scientist E, Deputy Director at ICMR, National Institute of Research in Reproductive Health. Dr. Patil's role has been instrumental in devising the guidance of management of pregnancy in COVID-19 pandemic. Over to you, ma'am. It would be nice if you could share your slides.
Yeah, thank you, Surabhi. At the outset, I would like to salute the Ministry of Health and Family Welfare and the Maternal Health Division and all the healthcare providers in their tireless efforts in battling the COVID pandemic. I would also pay my deep respect to all the corona warriors who are fighting the pandemic and also those who have sacrificed their lives in caring for our patients. In my presentation, I would be covering the COVID-19 testing protocols, effects of the COVID-19 on pregnancy and complications. So this guidance material was also translated in Hindi in the local languages, Hindi and Marathi, and it was handed over to the state government. So coming to the symptoms of COVID-19, in a report from the CDC, which included around 23,000 pregnant women, and they also looked into the non-pregnant women of reproductive age group, and they looked into the frequency of the most common symptoms in each group. And as we can see, the symptoms, they don't differ much in the pregnant as well as the non-pregnant group. The predominant, the most common symptoms which are seen are cough, headache, muscle aches, fever, sore throat, shortness of breath, and new loss of taste or smell. What is important to note is that many pregnant women, they are asymptomatic, but the proportion of asymptomatic cases is not well defined. And this is very high. It's to the order of around 73 to 95%. And that is why it was made mandatory to test all pregnant women in labor. And also it is important to note that some of the clinical manifestations of COVID-19, they do overlap with the symptoms of normal pregnancy. Next slide, Surabhi. As Padmini madam also rightly said, it is very important to classify the disease severity because it is important to decide where to refer the patient depending upon the disease severity. The National Institute of Health has categorized the degrees of disease severity into asymptomatic or pre-symptomatic infection. Now, what is this? This would be a case where which would be tested positive for SARS-CoV-2, but there are no symptoms. Second would be mild illness. This could be any signs and symptoms which are not severe enough, like fever, cough, sore throat, malaise, the general influenza-like illness symptoms. But this has to be without shortness of breath, dyspnea, or any abnormality on chest imaging. The third would be moderate illness. In this, there is evidence of lower respiratory tract disease by either clinical assessment or imaging. And the oxygen saturation has to be above 94% at room air level without any oxygen support. The next category is severe illness. In this, the respiratory rate is above 30 per breaths per minute, and the oxygen saturation is below 94%. Also, on chest imaging, the lung infiltrates are more than 50%. And the final stage is of critical illness, which ends up in respiratory failure, septic shock, or multiple organ dysfunction. Now coming to the testing strategy. The OBGYN and maternal care providers should contact their local or state health department for the guidance on testing persons because this testing advisory is revised at repeated time intervals. Also, they should notify the infection control personnel at their healthcare facility and their local and state health department in case there are COVID positive cases or persons under investigations. Also, it is very important that the maternal and neonatal records, including the outcome, should be completed in detail and preserved for analysis in future. Now, coming to the testing, whom to test? All pregnant women with symptoms which were mentioned before have to be tested. Secondly, asymptomatic pregnant women with history of close contact with a COVID positive patient. All women in labor with or without symptoms have to be tested, and all neonates have to be tested. Now coming to the test, which test is to be done? Ideally an RT-PCR, but now we have the revised testing strategy and the advisory for COVID-19 testing during the second wave of the pandemic, which is released by ICMR on 4th May 21. In this, the RAT testing has been stressed upon. And if the RT-PCR testing is not available, then the RAT testing has to be done, and it has to be done with the kits which are approved by ICMR. Now, what if the RAT test is negative? If the RAT test is negative, if the RAT test is positive, it means that the woman does have COVID positive. But if the RAT test is negative, still the woman might have COVID positive. She might still be positive for COVID. In that case, this has to be confirmed by an RT-PCR test. Now, what is the maternal course during this COVID infection? As far as the evidence which is available as of now, pregnancy does not increase the susceptibility to SARS-CoV-2 infection, but appears to worsen the clinical course of COVID-19 compared with non-pregnant women. So women who get COVID-19 when they are pregnant, they have a more worse course with respect to COVID-19. So although that is more than 90% of infected pregnant women recover without undergoing hospitalization, this is a very positive aspect. There is rapid clinical deterioration which can occur, and symptomatic pregnant women appear to be at increased risk of developing severe disease and complications and death. This is what is important is the risk factors. The risk factors for severe disease and death in pregnancy include an older mean age, that is more than 35 years, obesity, pre-existing medical comorbidities, particularly hypertension and diabetes. In a systematic review, the odds of death in studies of pregnant women with COVID-19 are higher than in uninfected pregnant women, but not higher than in non-pregnant reproductive age group females with COVID-19.
रोज क्यों फोन कर रहा है? शकील फोन करके पूछना.
Now coming to the complications. The spectrum of the clinical course of COVID-19 in pregnant women was studied in large data sets. And in a systematic review of 192 studies, including over 64,000 pregnant women, which was published in BMJ in 2020, women with suspected or confirmed COVID-19, most of these women, among the complications, the most common complication which was seen was pneumonia, which was seen in 17% of women. 17% of women did require oxygen, 13% had ARDS, 11% had severe disease, around 3% of women required intensive care admission, 1.6% required invasive ventilation, 0.1% required ECMO, and 0.8% died due to COVID infection. Also, it is important to note that some patients with COVID-19 have a laboratory evidence of an exaggerated inflammatory response, which is similar to the cytokine release syndrome, which has been associated with critical and fatal illness. Now, what are the common complications seen in women who get COVID during pregnancy? The most common complications are respiratory complications like pneumonia, respiratory failure, and ARDS, which are life-threatening. Then also COVID leads to COVID myocarditis, which leads to arrhythmias and acute cardiac injury. There are thromboembolic complications which happen, secondary infections, acute renal failure, neurological disorders, in which the disorders of smell and taste are very common. Different types of skin rashes can be seen, and also there can be GI effects like diarrhea and alterations in the liver function test. The most commonly seen psychiatric issues with this condition are depressive disorders, and it is very important to look into the mental health status of these women. Now, one of the common questions which is asked is how common is the congenital infection in these women and what is the risk of teratogenicity, and whether MTP should be done if the woman acquires COVID during pregnancy. Now, to this, the literature is not very clear. It is still a gray area, and the extent of vertical transmission remains unclear. There are only very few well-documented cases which suggest probable vertical transmission which have been published. In a systematic review of infants, which was infants born to 936 COVID-19 infected mothers, the neonatal viral RNA testing was positive in 27 of the neonates. Nasopharyngeal samples were taken immediately after birth or within 48 hours of birth, and there was one sample in which in the
Sorry to
corridor
interrupt
sample.
you, ma'am. 15 minutes are about to get over. Please explain.
Okay, yeah, okay. So basically, whether there would be congenital, there is no risk of teratogenicity, and the risk medical termination of pregnancy is not indicated in women who contract COVID-19 during pregnancy. Now coming to the maternal and perinatal outcomes, as Sir has rightly mentioned, the global maternal and fetal outcomes have worsened during the COVID-19 pandemic with respect to maternal deaths, stillbirths, ruptured ectopic pregnancies, and maternal depression. However, with respect to other morbidities, there is not much increase. One positive thing is that the neonatal outcomes are good in women who get COVID-19 during pregnancy. Also, there is a disparity between the high resource and low resource settings, and therefore there is an urgent need to prioritize safe, accessible, and equitable maternity care within the strategic response to this pandemic in all future healthcare crises. So this is the last slide. Yeah, thank you.
Thank you very much, ma'am. Now we will go next. We have Dr. Poonam Varmashiv Kumar Amitsas. Dr. Poonam is Professor and HOD OBGY at MGIMS Sevagram Varta. Madam has been an indispensable member of various technical expert groups notified by MHFW and has contributed to numerous maternal health guidelines. Over to you, ma'am, for your presentation on triaging COVID-19 and pregnancy.
Thank you, Surabhi. And thank you, Ministry of Health, for this opportunity. I'll just share my slides in a minute. So a very good afternoon to everybody, and a great thanks to all of you for this opportunity. What I'm going to talk to you today is about the triaging of COVID-19 in pregnancy and what difference does it make if we do that. The same issue is there that I'm not able to,
I will help you.
Okay, all right. So I bring greetings from Mahatma Gandhi Institute of Medical Sciences, which still is an institute where a lot of ethics are followed, and we are really doing good as far as the triaging of COVID positive patients is concerned. Please go ahead. So there are certain facts which I would like to talk to you. The data pertaining to COVID-19 pandemic is rapidly evolving, and all of us do not know what's going on and what is right and what is wrong. And we are learning, and every day we are trying to make the guidelines which benefit our patients. There are several conflicting reports, and if we see that the first pandemic, probably pregnancy was not that issue, and we had not seen so many deaths. But coming on to the second wave, we are seeing that many women are dying and many severe cases are coming. The virulent strains are affecting the pregnant women very badly. And if we go on to this particular study, which is the most recent one, we can see that in US, 47% women were asymptomatic, 27 were mild, 14 were moderate, and 8 were severe, and 4 were very critical. A similar kind of data has been with us also when we evaluated our cases, but we were much better. 85% of our cases were mild, 15% were moderate, and 5% were severe, and only 2% were critical. And if you see into the various symptoms, believe me, the people are saying that there have been various symptoms, but yet women are coming with the major symptoms of fever, cough, myalgia, and shortness of breath. Another symptom which has added is diarrhea. Go ahead, please.
You could see the next slide.
Yes, Doctor.
Ma'am, please proceed.
Okay.
Please proceed.
So we all know that the common reported symptoms are there, but the question which comes to our mind is that, of course, in mild cases, we do not need to do any HRCT. But for sure, in moderate to severe cases, there have been recommendations that maternal life is more important than fetal life. And if HRCT is needed, then it should be done. and the government recommendation is also such. There have been no changes what have been seen in vaginal and cesarean section delivery, and COVID is not an indication for doing cesarean section. That has to be very clear in our minds. And the vertical transmission of neonate, which when the first wave was there, it was negligible, but now there are some reports coming that there have been some reports saying that probably there is some percentage of vertical transmission going on. And of course, what would be the morbidity and mortality we need to look into later. Two important things which we need to really look into is, and during the triaging, you come to know a lot many things, and this is the mental health, because there have been such a fear factor nowadays that the women are almost anxious, apprehensive when they come, and even if they are positive, if you ask them to get admitted to the COVID hospital, they do not go. And violence against women is another concern which we need to look into. Now, when we look into the antenatal, intranatal, and postnatal care in COVID positive women, there are three pillars which we need to look into, because we still say that RMC has to be given whether it is COVID positive case or it is a COVID negative case. So it's very important that we look into these three things. One is infrastructure, another is a skilled human resource, and third is evidence-based updated protocol. And in a minute, I would like to exactly elaborate on them. You see, none of us had the infrastructure where we would have oxygen beds and things like that, but the government has helped so much, whether it is central government or it is the state government. They have provided enough funds to develop those, and very quickly the hospitals have taken up, and the dedicated COVID hospitals have developed their scenarios. So it's the infrastructure which we have to look into, and in that infrastructure, we have to see how do we triage, how do we create a suspected area where the suspected cases can be kept, or isolation area, and where we can keep the COVID positive cases. When we say skilled human resource, believe me, if you do donning doffing in a wrong way, you're going to get COVID cases. I mean, you yourself may get COVID. So in that case, it's very important that we learn these methodologies, how we have to do so. The whole human resource which you are posting to COVID or an isolation area needs to be strengthened in their capacity and skills for how to deal with these kind of cases. I repeatedly say, please do not make your own protocols. Look into the protocols, and people have the habit of looking into ACOG, RCOG. They are very good. But Government of India, whenever they make the protocols, whenever they make the guidelines, you see the panel which sits, it looks into each and every guideline, be it Canadian, be it American, be it UK, wherever, and then only the Indian government guidelines are developed, looking into everything and also looking into the Indian scenario. Go ahead, please. Now we look into this institutional system which we need to develop. There has to be a non-COVID area for the pregnant women, antenatal women, and laboring women and PNC women. There has to be an institutional area for isolation where suspected pregnant women, and this is the area which is very, very critical. Why? Because two patients, one is positive, another is negative, and the negative patient should not get COVID from the positive one. So this is an area where human resource, etc., has to be looked into. And then, of course, you have a COVID block where you keep COVID positive pregnant women and laboring women. Go ahead, please. Now, I have been repeatedly telling that triaging is something which has helped us in maintaining a very good scenario in our institute, and we recommend strongly that these cases should be triaged, and only a trained nurse is needed 8 hourly for doing this kind of triaging, where you separate all three areas. Go ahead, please. Why triaging in COVID-19 is important? Because it provides an appropriate environment for assessment and management of all antenatal, laboring, and postnatal women, where emergency and elective services can be given. It provides an efficient service to appropriately screen the women who are either suspected or are COVID positive. This minimizes the spread of COVID infection, and it gives a care pathway in order to ensure that the pregnant women are transferred to the right place without delay and given right treatment. And of course, in this area only, you also identify whether they are mild, moderate, severe, or critical. Go ahead, please. Where should be this place of tri-age camp? So it is called a gateway. It should be very close to the entrance. It should be spacious. There should be a place for health worker to sit with all precaution. There should be a place for the women to sit with distancing. There should be a place where, privately the history can be taken, etc. and etc. And then there should be an examination area which should be fully equipped to examine this particular women in safe scenario. Go ahead, please. What is the method of triaging? So as I told you, a healthcare worker who does triaging has to be trained well in COVID-19 disease. She sits in the screening area, triaging area with PPE on, and he should know or she should know what history she is supposed to ask, what investigation she needs to see, when she has to call the doctor for examination, and how do you differentiate with a checklist amongst these. And this particular healthcare worker could be a staff nurse, it could be an intern or an in-charge sister. The checklist has to be developed, and the women and the triaging nurse has to be trained in that. Go ahead, please. So what are the contents of checklist? I'm not going to go in details. We all know that what are the questions we need to ask. So we need to ask about her address. Where does she belong? Was she having any comorbidities? Does she have any symptoms at the moment? Has she been exposed to somebody who had COVID positive? Is she coming from containment zone? Go ahead, please. And then we need to check the investigation, because many a times she is COVID positive, but she, does not show us the report. So you just have to ask all the reports and look into the investigation, and then we decide where she has to go. And then when examination is needed in that particular triage only, where the examination area is there, the doctor is called, who comes in PPE, examines the women, and there only pulse and pulse oximetry is done, blood pressure is checked, and respiratory rate is noted. And then she's classified into non-COVID, COVID, and suspected area, and shifted to the respective area. Now, this is just a flowchart. In a minute, I will describe that. If she's found to be negative, I'm not going into details because we have slightly less time. So we have to understand that she's COVID negative. There is an area which is COVID negative in the hospital. She goes there. If she is antenatal with complications, she is admitted. If she does not have complications, she is sent back home. And if she is laboring, then she is delivered. Here, one question is there, even in non-COVID area, when you are allowing birth companion, please take a small history and look into certain findings before you allow this birth companion, because one birth companion positive is going to give to all negative women and all the laboring women who are there, the COVID infection. When she is suspected, she's taken to a particular area where the two beds have a distance of 6 feet or more, where again there is very restricted entry of the birth companions, and she is dealt according to the disease she had, mild, moderate, severe. And we wait for the report. We do RAT for everybody. So it is recommended that if she is getting admitted, you must do RAT. RAT positive, you need not do RT-PCR, but RAT negative, please send RT-PCR, let the RT-PCR report, let her be in the isolation area. And once you have RT-PCR report, then you can shift her either to COVID or to a non-COVID area. And once she's COVID positive, she's immediately shifted. Every hospital has a very interesting referral system. That's what we have. The ambulance driver and all, there is a sort of plastics kept so that the driver also does not get infected. He comes in PPE and takes this particular patient, and she goes on to the COVID ward, where she is divided into moderate or severe cases, and accordingly she is put in the ICU or in an area which is for moderate cases. Go ahead, please. And this is again those just few points that the team examines the patient in COVID suspected area. once the patient is shifted, and then they decide whether they have to send the patient for home quarantine or they do not, because the reports are yet to come. Whereas in COVID area, they take them to the particular place in the hospital. I'm not going to elaborate on this. Go ahead, please. Classification has been very well said, but here remember, in triage, you cannot have too many parameters to assess the women. So your decision would be that she's mild, but later on with the report, she may come on to be moderate. So triaging is some place where you just looking into certain symptoms, SpO2, respiratory rate, and some markers if they are available and their symptoms. You approximately say whether she is mild, moderate, severe, or critical. Critical and severe, they are very obvious. Mild and moderate, you have to decide whether you would like to admit or would you like to send her for home quarantine. Go ahead, please. Now, these are recommended investigation which we do from triaging itself. Of course, the routine investigation you all know, but there are very specific investigations, set of investigation which are done in triaging for these particular women. For mild disease also, the recommendation is that you must have the baseline data so that in case they are deteriorating, you would look into that trend and then you will decide whether they need to be labeled as moderate and shifted to the particular area. So this is particularly for the cases which once come positive, then you have to go ahead with these investigation, in which CRP, D-dimer, serum ferritin has been given quite a great importance, and interleukin, LFT, KFT, X-ray chest, HRCT, when she is already diagnosed to have moderate to severe case. My last two slides are that we would, there are some innovations which are coming up. You see, we are very, we have very scarce human resource. And all of us know it's becoming very difficult to manage three areas, non-COVID, isolation, and COVID, 8 hourly duty, or to reduce them to 6 hourly duties so as less exposure is there, because a lot of healthcare workers are getting infected. So do we have, although we have separate LDR and separate OT we have created for all these three places, and that's what recommendation is. But can we think in terms of hybrid, because this woman is highly infected and any little infection can kill her. So can we have a hybrid LDR and OT where the women is in all those aseptic precautions where you do cesarean section, the similar precautions are done for labor room as well. And there is a curtain or a, what you say, a platform which separates these two areas, but the staff remains same for these two areas. So we would be reducing the human resource significantly. And then, of course, the birth companion needs to be discussed.
Ma'am, your time is over.
Yeah.
Please activate.
Yeah, go ahead, please. My last two slides are there. Teleconsultation is a very important thing which we all need to look into. Rural area, things are very different. These consultations may be misinterpreted, whereas on the other side, things are very good. Teleconsultation is going on and it has been recommended by court as well. So let's look into this and how we can benefit our clients. Go ahead, please. And these are the challenges which I would just like to mention in a second. Asymptomatic women are coming. When we see them, when we do everything, then they come out to be positive and we all are exposed. Rat test is coming negative in many, but RT-PCR is coming positive. Patients are definitely hiding the history. Once they get admitted, then only they reveal. They refuse to get admitted to COVID block because of the fear factor. There's a huge lack of human resource is still going on. Quality and skill of human resource is a major question. Government is recommending that interns should come, final year PG should come. But can you utilize them in the ICUs? Can you utilize them in HDUs? They do not know anything except putting on the oxygen. So do they need to be trained first and then they should be sent to these areas, because it's question of somebody's life. Night shifts are very difficult again because of lack of human resource. And then this is a very important thing that we need to involve psychologists. And we have seen that when the psychologists are talking to our people, people are really becoming much better, and number of cases of suicides are reducing with the help of these psychiatrists. Thank you so much for your patient hearing. These were my views, and I would like you all to please look into these challenges and help us out. Thank you so much.
Thank you very much, ma'am. I request you to stop sharing your slides so that we can proceed for the next presentation. Next, we have Dr. Aparna Sharma with us. Dr. Sharma is Additional Professor, Division of Maternal Fetal Medicine, OBGY at the All India Institute of Medical Sciences, New Delhi. I request ma'am to take us through the management of COVID-19 during the antenatal period. Over to you, ma'am. Dr. Aparna, I request you share your slides and then I will help you maneuver with the slides.
Thank you, Surabhi. So a very good afternoon to everybody. And I'm really thankful to the MOHFW, Dr. Sikdar and Dr. Padmini and the whole team for having me here. And I think it's a very timely intervention for us, for all of us. So I will divide my presentation into 4 parts. 2 of them have already been covered, so I'll be very quick about it. Next slide, please. Whether COVID affects mother. In very, very short, pregnancy does not increase the risk of acquiring infection, but if infection occurs in pregnancy, the risk is slightly increased of the complications. However, the good news is that 90% of the women will recover without any problem, but there are some complications which increase in pregnancy. Next slide. What about, but we need to really look into the mothers with comorbidities like hypertension, diabetes, asthma, heart disease, HIV, and any chronic illness in the mother, and we need to be more careful about it. Next slide, please. What about the infection in the fetus? Next slide. As Dr. Anushri has already told us, do not look or get too much worried about whether it is congenital infection, transmission, or vertical transmission. So the evidence till now is not very robust. So at this point of time, for all practical purposes, I am not too much worried about the baby getting infected through the placenta or through the mother to the baby. Whatever babies are getting infected, it is in the postpartum period. So let us be not very, very concerned about it right now. So next slide, please. Now we have 2 aspects of antenatal care. So antenatal care in non-COVID pregnant women and antenatal care in confirmed COVID pregnant women. Next slide. Now, even if we are in the era of COVID positivity, we should not ignore essential services. That includes antenatal care for non-pregnant women. And why it is important? Because there is infection to the mother, infection to the newborn, and an infected pregnant woman can spread infection to another pregnant woman during the process of antenatal care, and an infected pregnant woman can spread infection to the healthcare providers. Next slide, please. So it is very important to understand how to optimize antenatal care. The number of ideal antenatal contacts have to be reduced. Number of visits is supposed to be 4, and the schedule of visits is as follows: 12, 20, 28, and 36. So just remember, do the 4, 12, 20, 28, and 36. Next slide, please. So we have to reduce the number of visits, increase the interval between visits, shorten the duration of visits, and do not bring visitors when you come at the visit. Increase the teleconsultation. Virtual visits have to be increased rather than physical visits. Next slide, please. What do you do at 12 weeks? Confirm pregnancy, screen for high risk, do the baseline investigation, start folic acid and iron. Second visit, assess fundal height, do a good ultrasound to rule out fetal malformation, immunize with TT, and continue iron and folic acid, calcium intake. Next. At the 3rd and the 4th visit, continue to do your routine antenatal care, educate patient, counsel for warning signs. At the 4th visit, assess for fetal growth, assess pelvic adequacy, instruct about warning signs, and watch for complications. So this is your general outline, and in a low-risk pregnancy, 4 visits are more than enough for a good antenatal care, which was your classical FNAC model, FANC model. So this is what you need to do. Do not call the patients too often. Next slide, please. For care at home, advise a good balanced diet, advise her blood pressure monitoring if possible, maternal weight can be done at home, and daily fetal movement count after period of viability. Next slide. Next slide, please. Yes, now we come to the most important part, and because from obstetricians we are becoming medicine people, this part is very important, how to manage COVID positive women. Next slide, please. And on this, I will spend some time on understanding how to manage COVID positive women. Assessing disease severity, definitions have been discussed by both Dr. Anushri ma'am and Dr. Poonam. But is the disease severity different in pregnancy? Next slide, please. Typically, the disease severity has been defined by AIMS definition as SpO2 less than 90 for severe disease, while for moderate, it is less than 93. But what happens in pregnant women? Next slide, please. So by the definition of Society of Maternal Fetal Medicine, it says that you have a moderate disease as long as the saturation even in the moderate disease, the saturation has to remain above 94%. In pregnancy, if the saturation is falling below 94%, you have to consider it as a severe disease. Now, this definition has been given by the Society of Maternal Fetal Medicine, and we can understand that it is better to err on the side of a higher saturation before calling it a severe disease. And this is a bit of a change when you try and define severity in pregnancy, and we have to keep this in our mind. Next slide. So what happens if a pregnant woman turns out to be COVID positive? First of all, we need to tell them not to panic. It is all right. We are handling these patients day in and day out. Please contact your maternity team, and most of the cases can be managed at home. If, however, there are some signs of severity, the maternity team has to be counseled urgently and they will require admission. Next slide, please. So we need to understand, next slide, we need to understand that if a patient is asymptomatic or mild symptoms with no comorbidities, as I had shown on the third slide, with no obstetric emergency, and the patient is not in labor, if all three criteria are met, the patient can be sent for home isolation. See, we are different from medicine people that we have to at all times consider obstetric emergency and labor. So the third aspect here is very important. So please consider all three criteria are met, send the patient for home isolation with adequate precautions, and fetal monitoring can be done after 2 weeks with growth and Doppler. Next slide, please. What are the tips on home isolation? Next slide. So the tips have to be given to the patient and to the attendant. So in your home, isolate yourself in a well-ventilated room. Do not share your personal items with other people, and ensure cleaning of surfaces frequently with 1% hypochlorite. At all times, maintain respiratory and hand hygiene with a triple layer medical mask, which should be discarded after 8 hours of use, and respiratory etiquettes at all times. Frequent hand washing with soap and water at least for 40 seconds, and drink lots of fluids, which you would do in any viral infection, with a lot of rest. Next slide, please. Self-monitoring, this chart is extremely important, which you should advise your patient that every 4 hourly, please take your temperature, heart rate, SpO2. Are you feeling better? Are you breathing well? Do you think your breathing has increased? So this is something that you can advise your patients at the time of home monitoring. Next slide, please. Also, tell the attendants to wear a mask, N95, when they are in the same room. The front portion of the mask should not be touched. The mask should be discarded after when hand hygiene should be performed, and food must be provided to the patient in the room, and the utensils should be washed with soap and water, wearing gloves. Next slide, please. So these are some of the very important instructions that you give. What treatment is to be given? Nothing much. Just give them PCM. Paracetamol, if it is not responding, it has been seen that naproxen has been seen to have a good effect on patients who are having fever. Next slide, please. What to do after 2 weeks of illness is that if the patient is in the first trimester, do a detailed anomaly scan at 18 weeks. In the later half of pregnancy, do a growth scan after 2 weeks. So this is all that you need to do regarding the fetal part. Do not worry too much about it. Now, next slide, please. Unnecessarily do not advise growth scans in between those 2 weeks, or GTT has been missed. You can do after 2 weeks. Do not advise antenatal appointments in between. If there are any particular severe fetal concerns, then the maternity team should be contacted for an emergency appointment. Otherwise, patient can come back to you after 2 weeks with only daily fetal movement count. Next slide, please. Now, the most important part is the patient is on home isolation. What are the danger signs that you should tell the patient? Next slide, please. So this should be divided into symptoms and signs. The symptoms: worsening, shortness of breath. Patient is now having dyspnea, which was not there before. Increasing dyspnea, fever which is not responding, persistent fever, then chest pain. Patient is not able to keep anything down. There is new onset confusion, lethargy, or definitely any obstetric complaints. On signs: tachypnea, increasing respiratory rate, unremitting fever, oxygen saturation less than 95, or cyanotic. So all of these things you need to admit the patient. Next slide, please. Protocols: when you admit the patient for moderate disease, every 4 to 8 hours, you need to monitor the patient by temperature, heart rate, respiratory rate, blood pressure, and pulse oximetry. But moderate to severe disease, you need to increase 2 to 4 hourly inpatient. You have to monitor. Next slide, please. Now, when to investigate? So generally in the mild form of the disease, not much of investigation is required. Like for the first 5 days, you don't really need too much of investigations. But in the moderate disease, you need to do the inflammatory markers and also the basic complete blood count, absolute lymphocyte count, and the KFT and LFT. Next slide, please. Remember these values. Just remember these values. SCRP of more than 100 in pregnancy is abnormal. D-dimers more than 1000 become abnormal. Ferritin more than 300 or LDH more than 400. So if these start raising in the moderate disease, this is something which you need to worry about. Next slide, please. So drug therapy. So I will just summarize the drug therapy like. Next slide, please. When to start oxygen? When your saturation is less than 94%, you will start a mask or a cannula. Keep the patient in prone position. Continue fetal monitoring beyond the period of viability. And if there is no improvement despite then, you need to keep your anesthesia colleagues in the loop. Next slide, please. Steroids. I think this is most important. So there is no confusion that in moderate cases, you will give steroid, that is your saturation is falling or your persistent fever, or there is rise in respiratory rate or fall in SpO2, then you will give steroids. But even in mild cases beyond 7 days of illness, you might consider steroids, but it is very, very important that this needs to be given in association with consultation of your physician friends. Next slide, please. If steroids are needed for lung maturity, please give the usual dose of dexamethasone for 4 doses followed by dexamethasone to complete the usual course of treatment for maternal COVID. So this can be done perfectly well. Next slide, please. Anticoagulation, most important because we know pregnancy is an additional risk factor. Please do VT assessment. Anticoagulation is indicated for all cases of moderate to severe disease who are being managed inpatient. There is no confusion about it. It is not indicated for mild disease or asymptomatic or mild disease who are hospitalized for other reasons like, preterm labor or premature rupture of membranes. So that is the situation. Next slide, please. Postpartum cesarean dissection done, immobilized patient again to be considered. If you have started anticoagulation, to be given at least for 10 days. Again, VT decision, anticoagulation should be individualized. Next slide. Next slide, please. Other drugs like remdesivir has to be given in consultation with your physician colleagues for the same indication, and it has no known fetal toxicity. If it is indicated, you can give it. Similarly, TOSI, not enough evidence to support its use, but it is not an absolute contraindication. Next slide. Ivermectin, it is specifically to be avoided in pregnancy. There is low evidence on safety. Similarly, doxycycline to be avoided. Monoclonal antibodies, no evidence of safety, but no absolute contraindications for its use in pregnancy. So only when its risks are lower than the benefits are more, only to be used. Next slide, please. Next slide. Most importantly, to understand when to admit to ICU, persistently, if you are unable to maintain saturation more than 95 despite giving maximum supplemental oxygen, persistent hypotension, or new organ dysfunction, admit to ICU. Next slide, please. Timing of intubation. Persistently, when you are trying to give oxygen more than 15 liter per minute by your common nasal cannula and you are not able to maintain saturation, time to intubate this patient. By HFNC, more than 50 liters per minute, time to intubate. More than 60% by a Venturi mask, then you need to intubate this patient. Next slide, please. Prone position is possible in pregnancy. If it is needed, please go ahead and do it. Next slide. What to do when to deliver? Next slide, please. Now we have a severe confusion after 32 weeks whether to deliver or not. Next slide, please. In this, I would like to say, please take the help of your anesthesia colleagues. If there is refractory hypoxemia, that means despite your mechanical ventilation, despite your high flow nasal cannula, the partial pressure of oxygen is not improving. It is still less than 70 at an FiO2 of 100. Then you know that your ventilation is not working. The patient is more than 32 weeks. You do not have a facility for ECMO. Then it is time that you deliver this patient. There is uniform guidelines, more than 32 weeks, patient is not improving. Then you have a strong case to deliver this patient to improve oxygenation in your patient. Next slide, please. So to summarize the management in one slide, please see the green part first. If the patient is mild COVID, in the first and second trimester, consider home isolation, symptomatic management. In the first and second trimester, review for visit after 2 weeks. Please do not hurry to visit in between. Sonographic assessment of fetal and anatomy or growth as appropriate. In the third trimester, if it is mild COVID, please also consider whether you need to deliver the patient. It should be according to your obstetric indication. Do not delay if it is indicated as preeclampsia or whatever your obstetric indication. So please follow me on the green part, which is the mild COVID. Now for moderate COVID, which is reflected by dyspnea, refractory fever, pneumonia, or abnormal blood gases, please admit the patient. Admit the patient, investigate the patient, follow up the patient in your ward. Again, in the first trimester and the second trimester, you would need to start the patient on steroids, anticoagulation. Do not forget to start anticoagulation in pregnancy. This is very, very important. Antibiotics is for community acquired pneumonia. You have to use according to your protocol. Again, in third trimester, obstetric protocols remain very, very important. There cannot be a blanket protocol where you say you deliver or not. So please involve delivery decisions. Please involve senior consultants. For severe COVID, admit in HDU ICU where the respiratory rate is more than 30 or SpO2 is falling to less than 94. Admit to HDU ICU, whatever facilities are available. Investigate. Again, start oxygen support as I suggested. Nasal cannula, face mask, first option. Second is high flow nasal cannula. If still not possible, go for NIV or mechanical ventilation in association with your anesthesia colleagues. Steroids, anticoagulation, antibiotics, decision for delivery. More than 32 weeks, severe COVID, you will have a strong case for delivering patients. Next slide, please. So to conclude, pregnant women would follow the same recommendation as non-pregnant women for avoiding exposure. In antenatal period, there is something called shielding, which is the extreme form of isolation. So pregnant women should be told that you have to take extra care, not just pregnant women, but the family members of the pregnant women. Antenatal care through teleconferencing and video conferencing should play a key role in antenatal care. Triage should be based on symptom severity. Please include obstetric emergencies for triage. So addition to moderate, any obstetric emergency is an indication for admission. Multidisciplinary approach to management of suspected and confirmed cases. Please include your medicine colleagues if possible in all cases of management. And the detailing of medical management is here because we also understand that in the second wave of COVID, we have become a lot of medicine and physicians and not just remained obstetricians. Thank you. And I hope that this will come of some use. Thank you.
Thank you very much, ma'am, for such an elaborate presentation. I would request you now to stop sharing your presentation. Now, without further delay, I would request Dr. Manju Puri to take us through the management of COVID-19 during intrapartum and postpartum periods, covering the breastfeeding in COVID-19 also. Dr. Puri is Director Professor and HOD OBGY at the Lady Hardinge Medical College, New Delhi, and Chairperson of Safe Motherhood Committee of AOGD. Over to you, ma'am. I request you to share your slides. I will facilitate the changing of slides.
So good afternoon, everyone. And after some very nice, crisp, very clear presentations from Dr. Anushri, Dr. Poonam, and Dr. Aparna, I now move on to the next part, which is the intrapartum and postpartum management in patients who are COVID positive. Next slide, please. Just a second, please. Yeah. So we know that pregnancy in pandemic is stressful due to fear and anxiety, both due to the risk, fear of infection, and also because of insecurity whether a patient would get care during, when she needs it or not, also kind of plays on the mind of people, patients and their family. And labor and postpartum periods are even more challenging. And healthcare workers have an important role to play to provide respectful care, support, and allay the anxiety of patient and her relatives. Evidence on best practices in management of COVID positive pregnant women is evolving every day. So it is important for all of us to stay abreast with the latest and counsel the women and their families accordingly. Next, please. Yeah. So there are a lot of dilemmas as far as intrapartum care of the woman is concerned. With the first wave, everyone was scared. They would just, ask the patient to go to government hospitals, and not many people were delivering. And with the second wave, everyone is more prepared, and a lot of people are conducting deliveries. And we are also more comfortable as far as, we as healthcare providers. So a lot of dilemmas are there, which have been addressed in the previous presentations also. I'll reiterate all of them, whether to deliver vaginally or do cesarean sections, whether to allow a birth companion, and so on. Next, please. So the first and foremost is the mode of delivery. What is the right mode of delivery? In the first wave, a lot of people were doing cesarean sections for all these patients because, the labor was a long period and they would feel that the infection would, the healthcare workers would contract infection. But we have now robust data which says that, the rate of neonatal infection, the neonatal deaths, maternal deaths are all comparable. So, that is why vaginal delivery is the right way of delivering babies, and a cesarean section should be done only when it is medically or obstetrically indicated. So what is important is when the patient is for vaginal delivery, she should be delivered in the right dedicated place, and she should be instructed to wear a mask all through the labor, delivery and postpartum, because labor is an aerosol generating, event. So she should be wearing, and all the healthcare providers should be wearing a mask and a shield. Regarding the birth companion, it is it would vary depending upon the place where the patient is delivering, whether it is a public place or it is a private sector. So the birth companion, there is no contraindication to allowing a birth companion, but the birth companion has to be tested negative, and the same companion should stay with the woman throughout the labor. So and places which are overcrowded, it is better not to have birth companions unless the patient actually demands. Now, regarding the specific medical management, a very clear message and clear description has been given by Dr. Aparna. I would just want to say that please do not start all those patients who are tested on positive on screening with antibiotics and steroids as and once when they reach the labor room. So we don't need to do any specific investigations. We don't need to do any, start any medications in mild and asymptomatic patients. And they are like your normal patients. And in moderate and critical patients, the treatment has to be tailored in consultation with the pulmonologist or a physician who's looking after COVID patients in your area. What is important is if a patient is already on anticoagulants, it is important that as soon as the patient starts complaining of pain abdomen or she's goes into early labor, we should stop the anticoagulants. Low molecular weight heparin to be stopped 24 hours before the delivery, and unfractionated heparin to be stopped at least 6 to 8 hours before delivery. Otherwise, we should get ready with our blood and blood components and protamine sulfate. We also should be careful that we don't overload these patients with fluid. Next, please. Regarding the obstetric interventions, no specific interventions are required. The only thing is we need to take high-risk consents depending upon the condition of the patient. It is the routine care what we would give in first stage, except that we do monitor the respiratory rate and pulse oxygen saturation in these patients every 2 to 4 hourly, and make sure that the patient is well hydrated, because dehydration predisposes to thromboembolism. The patient should be allowed to ambulate if she can. She does not get breathless and does not desaturate. But in case she desaturates, then she needs to be kept propped up or in left lateral position. So oxygen, as already described by Dr. Aparna, we follow the same principles. We have to maintain the saturation above 95%. And regarding the cutting short of second stage, it is not to be done electively for all patients. You have to assess the patient in case she's unable to bear the stress of pushing during second stage. Of course, you can cut short the second stage by ventouse or forceps. Active management of third stage to be done like we do. And all related procedures like delayed cord clamping, skin-to-skin contact, early initiation of breastfeeding, everything needs to be done the way we would do for any other patient. Now the question comes that the patient was planned for a, say, elective induction of labor or elective cesarean section at 38 or 40 weeks, and we do a routine testing for that patient and she comes positive. So should we postpone our cesarean or induction or not? The answer is no. So if the induction or cesarean is actually indicated, it is important that we go ahead with it, because we don't know how the patient is going to do. She's going to be infective for next 2 weeks, and we don't know how she would progress. So there's no point postponing what is already indicated. But please make sure that unindicated inductions, unindicated interventions should not be done. Next, please. Glucocorticoids, Dr. Aparna has already said, so we need to give them. And remember, hydrocortisone and methylprednisolone do not cross the placenta as freely as dexamethasone and betamethasone. And if she was on prednisolone initially, you can give dexamethasone, then she can go back to prednisolone the way she is. But steroids not to be given for too many days for a very long time. Next, please. Yeah, now supposing a patient becomes antenatal patient who is under your care becomes COVID positive and she's term. So quite often you get a call asking whether you should terminate the pregnancy because you don't know how the patient is going to kind of, what is going to be the course of disease. Well, the answer is no. So if it is not obstetrically indicated, a COVID-19 positive status per se is not an indication for elective delivery. Now, supposing she develops it as at 39 weeks. Okay, so maybe you can do an assessment and consider termination at routine 40 weeks if you are doing so. Otherwise, the patient can be observed the way you would observe. The need for, even if a patient is on oxygen or she's on mechanical ventilation, it does not mean that you have to terminate the pregnancy. If she's still maintaining her oxygen, then there is no need to terminate the pregnancy. But the termination of pregnancy would be decided upon her condition, upon the period of gestation. Say if she is nearing term, so we understand that the enlarged uterus is going to restrict the ventilation. So that would be worthwhile in case we feel that the patient is likely, her condition is likely to improve after delivery. It would be worthwhile considering her for delivery. And cesarean section may be considered in a woman near term who is unable to maintain her saturation on ventilator or her her condition is worsening. So this is what is known as refractory hypoxemic respiratory failure. Next, please. So the key messages as far as intrapartum care is concerned, vaginal delivery is the preferred mode. Routine management of labor needs to be done like we would deliver all our patients. No specific medical treatment for asymptomatic or mildly symptomatic patients. Cesarean only for obstetrical indication. May be considered in case the patient is at term, if the patient is unable to maintain her oxygenation or ventilator. But in early pregnancy, there's no need to terminate pregnancy. And in the COVID status per se is not an indication for termination of pregnancy. and planned induction and cesarean sections need to go the way they are planned. Next, please. So the second part of my talk is the postpartum care. This is a very, very important part, and it is the most neglected part. And we know that majority of neonatal deaths and maternal mortalities would happen during the first 24 hours after delivery. So we really need to make sure that all healthcare providers maintain the continuum of care, whether physically or online through telemedicine with our patients, and make sure the patients are empowered as far as their care during this part is concerned. Next, please. So here the dilemmas are, should the mother baby, if the mother is positive, should the baby and mother be kept together, or can she breastfeed her baby? And do we need to adapt the postnatal care because she's COVID positive? So I'll just address these issues. Next, please. So whether they should be roomed in, the answer is big yes. Initially, we were keeping the mother and baby separated till such time the baby was tested. But now we do not have any such recommendation, because it is seen that whether you keep the mother baby together or you keep them separate, the baby, rather baby is more likely to contract infection if multiple people are handling her, because the relatives of the patient are also going to be likely to be COVID positive. So let the mother baby be with the mother, and there could be a healthcare care provider to help, who's tested negative, who can look after the baby, taking all COVID appropriate precautions. So breastfeeding is encouraged. Express breast milk can be given if the mother is unwell to breastfeed the baby. This is because the risk of transmission of infection through milk is very low. And if the newborns get infected, the disease is non-severe, and there is passive transfer of protective antibodies and anti-infective factors. And now we have studies saying if a mother is vaccinated, the antibodies, antibodies against COVID also get transmitted through the milk. And remdesivir is not a contraindication. Next, please. We really need to counsel the mother as to if the baby is kept in the same room as the mother, what precautions, mother-baby precautions need to be, taken. So the newborn should be kept in the same room, but 6 feet apart on a separate bed with a healthy caregiver who is tested negative and observes all COVID-appropriate precautions. And mother should wear a surgical mask. It is a surgical mask, not a cloth mask. And she performs proper hand hygiene before breastfeeding, giving skin-to-skin contact or routine care of the baby. Once she is breastfed, taken care of the baby can again go back to the healthy care provider. And so family education on infection prevention strategies is very important. They need to be told that not multiple relatives should come in and visit. So these are some glimpses from Lady Hardinge Medical College, where we have safe, social distancing, both in our antenatal OPD and also in our postnatal wards. Next, please. Yeah, now regarding the specific care during antenatal period, I think infection control precautions, everyone is emphasized. They need to be emphasized and re-emphasized at every, opportunity we get to interact with the patient and the family. The monitoring is as usual, but we focus on temperature, respiratory rate, and the oxygen saturations. These 3 things are additional, and of course the hydration status we need to look at. Analgesics, paracetamol, and naproxen, we can give non-steroidal anti-inflammatory agents. There is no risk of giving that. Thromboprophylaxis, I will just elaborate a little. Dr. Parna has already talked about it. If the patient develops fever postpartum, she was asymptomatic initially, then do not think it is only because of COVID. We need to rule out other causes of puerperal pyrexia like UTI, puerperal sepsis, and other things. Contraceptive advice, very, very important, because it may be possible the patient does not come back to you. So I think it is very important that we complete our counseling and do it very well. We cannot ignore this particular point. And of course, assessment of postnatal mental status, which we have a full session on. Next, please. So thromboprophylaxis, I said, because pregnancy per se, postpartum period, predisposes a patient to thromboembolism. And COVID on it, added on it, would further aggravate it. So we must avoid dehydration in the patient, encourage early ambulation, and do a routine risk assessment of all postnatal patients for thromboprophylaxis. We are not used to it, but we need to do it. And all
2 minutes left.
Yeah, I'm almost towards the end. So all high-risk patients need to be provided thromboprophylaxis. So in case it is to be given, no aspirin. Aspirin is not effective for thromboprophylaxis. That has to be low molecular weight heparin and in doses of 40 milligram per day subcutaneously. Next, please. Regarding the contraception, all methods are safe, but when you have a patient in labor room or you do a cesarean, please make sure that in antepartum period you've counseled her for, postpartum IUCD, which is a very good method. And then Centrome is also safe. You can give her. And mini pills can be prescribed as a bridging method till such time the patient wants to go in for some permanent method. Next, please. So discharge is as per routine. There is nothing, but make sure that the patient has home isolation facilities before you discharge her. So that is very important. Next, please. During discharge, it is important we tell the patient about the danger signs related to both postnatal period as well as COVID related danger signs. She should be told whom to contact very clearly. She should be provided with a contact number, where to come. She should contact through telemedicine. In case it is pressing, then she should come to a designated COVID casualty for next 2 weeks if she's tested positive on screening. And she should observe all COVID appropriate precautions when she comes, right? Next, please. So how long, this is my last slide. So it is important to counsel how long should they do baby mother precautions. When can the baby come on mother's bed? So if she is, tested positive on routine screening, after 10 days without testing, she need not go a repeat RT-PCR. So she can then have the baby with her. In symptomatic mothers, it could be longer till such time their symptoms disappear and they are afebrile without any antipyretics for 3 days. So these are the very recent guidelines which you can refer, revised guidelines for home isolation. Next, please. Next, please. Yeah. So my key messages as far as the postpartum care is concerned is that postnatal period is most crucial period both for the mother and the newborn, and this need not be neglected. The duty of a healthcare provider, be it an obstetrician, be it an ANM, ASHA, it does not end with the delivery of the pregnant women. Continuum of care is essential through teleconsultation or through physical visits. Breastfeeding counseling, contraception, postnatal mental health should be specially focused on during COVID pandemic. And detailed postnatal discharge advice and counseling is very, very important. So it is important that we all take care of our pregnant women and provide them with the best of services. Thank you so much for patient hearing.
Thank you, Dr. Manjapuri ma'am. I request you to stop sharing your slides now. Without further delay, we would move forward. The COVID-19 pandemic has had considerable impact on the mental health and well-being of individuals. Now I request Dr. Prabha Chandra to address mental health issues during the perinatal time. Dr. Chandra is Professor of Psychiatry and past HOD at the National Institute of Mental Health and Neurosciences in Bangalore, India. She is also the chair of the Task Force of Perinatal Psychiatry at the Indian Psychiatric Society. Over to you, ma'am. Dr. Chandra, I request you to share your slides. Okay, in this case, we'll move forward to Dr. Bhavna Gulati. Our next presenter is Dr. Bhavna Gulati. Reinforcing the message and investing in capacity building of infection prevention and control is paramount during such pandemics. We all know that. So without further delay, I would request Dr. Gulati to take us through the IPC and its importance during the COVID pandemic. Over to you, Dr. Gulati. Can you please share your slides?
Yeah, thank you, Surbi, for the wonderful introduction. So a very good afternoon to everyone. And I would like to thank the Ministry of Health for this wonderful initiative which they have taken at the right time. And I also thank you for the opportunity given. I must also say, following after this illustrious panel of speakers makes my job very, very easy, because we all know that clinical care and infection prevention control practices go hand in hand. So I've been asked to speak on IPC measures. IPC means infection prevention and control in COVID-19 times in labor room and OT. Next slide, please, Surbi. So we all know the principal strategies of IPC. There are many buckets. I think my previous speakers have already emphasized on most of it. We all know it also because we've been doing it in our day-to-day lives in our hospitals. Standard precautions or universal precautions, which we've been following on all the patients. Additional transmission-based precautions, which form the tier 2 precautions, which depending on the mode of transmission, in case of COVID, now we are following. And of course, a lot has been talked about triaging and early recognition. That means controlling the source of infection and segregating, positive cases, suspected cases, and non-COVID cases at the very start of the hospital. And of course, administrative and engineering and environmental controls. Next slide, please. Next. So I would just like to ask one small question to everyone. If everyone would like to answer with utmost honesty, in fact, before looking at the slide, do you think PPE is the most effective measure for controlling the spread of transmission of infection? Please write in the chat box yes or no. Do you think PPE is the most effective? We have been talking a lot about PPE, wear masks, wear gowns, wear gloves. Do you think it's the most effective mode of control? Please write in the chat box. The participants, please take a quick 1 second and write. It is not the most effective, though it is important. I'm not understating the importance of PPE. It is important, but of limited benefit if we do not implement the administrative and the engineering controls. PPE will give maximum benefit. Wearing PPE will give maximum benefit if we apply the administrative and engineering controls. In fact, if we look at the hierarchy of control, PPE comes at the least effective. So what are the administrative controls? Administrative controls is when you change the way you work. You bring a change in the policy. You bring on the change in the procedure. We've been listening to a lot of news where Modi ji has been consulting various states and districts. What is the change in procedure you would like us to do to facilitate your efforts? So the change in procedure, administrative controls, they're temporary solutions till we get more effective solutions in place. They could be simple ones like what we've been discussing, triaging, cohorting. What it is cohorting, we'll discuss. Limiting the size of people, like visitors restriction, limiting the staff which is entering the areas of care, especially COVID areas, universal masking, hand hygiene, separate routes, separate lifts for COVID patients. Those are the administrative controls. Basically, you change the way people work. Then it's the engineering controls. Engineering controls are the physical changes you make, like the distance between the two beds, 1 to 2 meters, right? You put exhaust fan, we're bringing in negative air pressure in these COVID areas, right? So that is your engineering controls. You're bringing in changes in the physical environment, right? And at the topmost of the hierarchy, you may also see elimination. That means you're eliminated the hazard by bringing, we have done so much in this last 1 year in COVID times on telemedicine, teleconsultation. Guidelines have come in from Government of India. So basically the doctor is at one place or the caregiver is at one place, the patient is at some other place. So the hazard has been removed physically from one place to another. So there is no exposure. So that's the most effective mode of control. Next slide, please. So as we have been, explaining, my fellow speakers have been explaining in the last presentations that we need to segregate right at the triage, at the beginning, and we sort out the patient so that there is no mixing. So then when we put the patients, so where do we put the patients? Ideal situation, if we can give an isolation room to every COVID positive case. But that is not true in our public hospitals. We all know that pre-COVID times, hardly any isolation rooms were there. And in fact, in last 1 year, lot of infrastructure work has also happened. So basically, this concept of cohorting means when single room is not available, you put the infected patient in a room where other patients with the same microorganism are infected with. In simpler words, if there are COVID positive cases there, ANC patient which is COVID positive, you put her in a room where other COVID positive confirmed cases are there. We have seen how last year when this COVID pandemic started, there was a lot of hue and cry where suspected cases were put along with COVID cases in the room. So that is not what we want to do. Cohorting means you put positive cases in a room where other positive confirmed cases are there, where suspects are there, you put other suspects. So you're putting people in the same room with same microbiology status, and when they're infected with the same organism, right? And only assigned healthcare workers must take care of these patients. Restrict entry of staff. Only allocated staff who are, who has been assigned to take care of patients in that area should enter into that area. Next slide, please. So PPE, rational usage. I think my fellow speakers have elaborated on usage of PPE, and a lot of importance has been given very rightly, because again, I would emphasize here the sequence of wearing PPE does not differ with the risk. It is the what type of PPE you select. What PPE you should wear depends on the risk of exposure. How much exposure to blood body fluids of the patients are you expecting? Number one. And number two is what category of transmission-based precautions has been allocated to that patient. If the patient is COVID positive, then there's a certain set of PPE you wear. If the patient is COVID negative, non-COVID, then there's a certain set of PPE you wear. If the patient is, if it's labor room, then the PPE would differ. If it's OT, the PPE would differ. Again, even the type of person and type of work. If it's a housekeeping person, it will be your rubber gloves, rubber boots, and the other PPE. But if it's a clinical doctor or a nurse, the PPE would be your latex gloves and your gowns. And of course, fit of the PPE is utmost important. Next slide, please. As you may rightly see on this slide, I can't see anything on this. Next slide, please. Yes, PPE is not the alternative to hand hygiene. I must emphasize here, hand hygiene and respiratory etiquettes are utmost important. PPE is not an alternative to hand hygiene. Next slide, please. In fact, in routine handling of patient, gloves are not even recommended. You wear your mask, you keep your distancing. In non-COVID, I'm saying the routine handling of patients does not even require gloves. Hand wash, hand hygiene is most important. Now, certain principles for use of PPE. Always clean your hands before and after wearing PPE. Ensure PPE is available where it's indicated. That means if your labor room, if a doctor is entering, or if a nurse is entering, or if a caregiver is entering, ensure PPE is available there at the point of care, not in some other room, right? And always ensure you put in your respective PPE before contact with the patient, generally before entering the room. That's why in our guidelines, in our Lakshya guidelines, we always used to emphasize in having a PPE corner before entering labor room, or there never used to be any donning or doffing rooms before. But yes, in last 1 year, we have created designated, if not specific donning rooms, at least donning areas where PPE can be worn. So it is important that in these donning areas, appropriate PPE as per that area should be available in the correct sizes, right? And in the correct number. Next slide, please. Now this PPE, now what PPE to wear? Now let's come to that. In fact, some staff, if they are confused, because we have staff across all levels. So rather than people getting confused, I'm just going to share what AIMS model. I've taken it from their HICC AIMS manual. It's a ready reckoner. It's a very well crisp ready reckoner which tells. So rather than telling each one, okay, you wear this as per this work, wear this. So they have divided into 3 basic levels depending on the risk of exposure in that area and the activity they are involved in. So level 1 will be a gown-based PPE kit. That means a gown could be your cloth gown, N95 mask, goggles, and gloves. Level 2 will be your coverall, right? Coverall-based PPE kits. Now the coverall will be again the material of the gown. It's a cloth here. So this includes your coverall, N95 mask, goggles, long shoe covers, and gloves. A third level will be your coverall, again the high end, the plastic coverall, the Kimberly Clark, which some hospitals may have access, some may not have access, right? Next slide, please. So what have they done? Depending on the scenario, depending on the area, they've assigned what PPE you should wear And if you need to do disinfection of that area, then what are you going to do? For example, as we were saying, there's a COVID suspect in a designated area of suspects, right? So if there's an ANC patient, which is a COVID suspect, so basically in labor room, if we have a COVID suspected area, level 3 PPE kit should be worn. Now, these are just suggestive. I'm just sharing. Each hospital must form their own SOP depending on the kind of PPE supply you're getting and the kind of services you're offering, right? The level of services, the scope of services offered by AIIMS will definitely vary with the smaller hospitals. So these are just guidelines for giving you a cue, but you must make your own SOPs based on the Government of India guidelines or state government guidelines in what PPE you should wear, and make it as a ready reckoner, put it on the walls of your organization. So in COVID suspected areas, you should wear PPE as if they're positive cases, and even the cleaning levels will be off as they're positive cases. No risk taking there. Even the cleaning would be two-step cleaning with detergent, then with disinfectant. Even biomedical waste management will be double-lined bags labeled at COVID waste, because they're suspected areas. Now you're awaiting RT-PCR report, antigen test may or may not have been done, patient is in labor, right? Next slide, please. Next slide. Subi, can you please make it next slide? Yeah. So in labor room, as such, if there is the normal labor room, they are saying that you can easily wear level 2 PPE kit. That means your normal cloth gown, if you're not suspecting it's a non-COVID area, a level 2 PPE kit with your routine disinfection as per routine will hold good. Next slide, please. I'm showcasing this as a ready reckoner of AIIMS guidelines so that, in case if you want to know more about the details, you can go into their website, download this, and you can recognize this, how I've just copied it from there, giving it a reference. Now, it's all OTs, they're recommending level 3 of PPE kit. Next slide, please. Now, principles for using PPE again. You must remove PPE immediately after the task is complete. Remove PPE at the doorway or immediately outside the patient room. The respirator or the mask definitely outside the room, not within the room. Remove the PPE doffing area. So there should be a clearly demarcated doffing room if possible. If doffing room is not possible, definitely a doffing area, demarcated area with proper biomedical waste management bins, and perform hand hygiene. Never reuse disposable PPE, right? So when you talk about doffing room, there should be a dedicated doffing area. Entry to the donning area and the exit from the doffing area should be separate. See, I must say that before we used to have one staff changing rooms. Now the concept has changed in for COVID, because doffing is a very, very high risk procedure. Maximum our healthcare professionals are getting infected at the time of doffing. So though it may take time, but do ensure that you spend that time to save your life, your family's life, and also to break the chain of infection to others. Now, preferably the doffing area should have a negative air pressure. You can have an exhaust fan there, and that area should be cleaned with 1% sodium hypochlorite after doffing is done. Now, what goes in what bin is very, very important. When you doff, ensure that by a simple word, peeli patti lal plastic. So whatever is infectious, non-plastic goes in yellow, whether it's your N95 mask, your triple layered mask, your head cover, shoe cover, your testing kits after autoclave, your swabs from patients, your infectious waste, your patient's placenta, any used cotton, everything which is infectious goes in yellow. Peeli patti. Next slide, please. Lal plastic. All plastics goes in red. Your aprons, plastic coveralls, gloves, your catheters. Except now here two things. Your face shields and goggles can be reused, but again, like in AIIMS, what they have done, they have made 3 red bins. So they have earmarked what goggles and face shields can go in 1 red bin because they are plastic, but again, they are cleaned with detergent and water, and after they are dried up, they can be clean with 70% alcohol, wipe clean, and then again reuse. The remaining can go in red, and then they can be disposed. Now, again, important in COVID areas that they should be double-lined bags, marked COVID-19 waste, and even on the bin, it should be marked COVID-19 waste with dedicated trolleys, dedicated the housekeeping staff, taking it to separate routes for handing over to the outsource agencies. Next slide, please. Now, considerations during severe shortages. Now, actually, reusage of disposable PPE is not recommended. For N95, yes, aims as a model of using 5 envelopes, which we all know that we can use each N95 for, like, mark them for day 1, day 2, day 3, day 4, day 5, and then each one can be reused 4 times. Thus, your 5 masks will last up to 20 days, right? And how long can you wear your PPE or surgical mask? Ideally 4 hours, but if the duty is extended till 6 hours, similarly your N95 up to 6 hours, but if it's extended up to 8 hours, but if there is any compromise, any tear, please change immediately. Next slide, please. Now, this is a checklist which I have just posted for your reference. Donning and doffing, if possible, should be supervised by a buddy or a fellow supervisor who ticks marks that whether are you doing in the right order or not. The sequence with which you wear PPE: first hand wash, shoe cover, first pair of gloves, gown, your mask, your goggles, your hood, your second pair of gloves. That order only is important that it is supervised. Next slide, please. Doffing, in fact, as I said, is a higher risky procedure than donning. So removing doffing is done exactly in the reverse order with hand hygiene at every step. It is important that you do hand hygiene between every step, and doffing again should be supervised by a buddy, by an observer, if possible, if you have the requisite staff. As I'm aware there's a severe staff shortage, but again, doffing is a very, very critical procedure. I'm just repeating. This checklist can be used. Now, biomedical waste management for COVID-19, as I've already said, the bag needs to be double layered and need to be labeled as COVID-19 waste. There is a mobile app, Biomedical Waste Management 19 CPCB, where we update the details of the waste generated. We keep separate records. There should be no mixing of COVID and non-COVID waste. And general waste should be handed over as general waste only, until it is infected by secretions of the COVID patient. Next slide, please. One thing which I forgot, that the bags should be disinfected with 1% sodium hypochlorite before handing over. Even the trolleys need to be disinfected with 1% sodium hypochlorite after they are used, even the bins and that surrounding area. In fact, one thing which has been really clarified by Central Pollution Control Board is 1% sodium chloride for all COVID things, whether it's environmental cleaning, whether it's biomedical waste management, 1% sodium chloride for use for all this thing. Now, environmental cleaning for labor room, we all know that it can be cleaned labor room to be cleaned every 2 to 3 hours. Floor can be with phenyl, and also between the cases, it has to be cleaned with the labor table can be cleaned with water and detergent. If it's visibly soiled, then with 1% sodium chloride can be wiped, and of course, by end of the day, terminal cleaning. The frequently touched surfaces like your door handles, your side tables, they need to be also be cleaned every 2 to 3 hours, right? Next slide, please. Now, environmental cleaning of OT, very, very important. Normally, we were cleaning OT with aldehyde-based disinfectants like bacillocid and all 3 times a day, like, first cleaning at the beginning of the day. Then we were cleaning between every cases and terminal cleaning. The schedule remains similar, but here again, 1% sodium hypochlorite for COVID OPT, for COVID OT. And in fact, even in your maternity OT, by chance, if there is a test which is, you have to take a COVID positive case and you're not able to refer it to a COVID hospital, ensure that the cleaning of the OT after you take the COVID positive case should include 2 levels of cleaning with detergent and water, with disinfectant 1% sodium chloride. All surfaces have to be wiped clean. Ensure all horizontal surfaces are wiped clean. Frequently touched surfaces are cleaned with that. And yeah, when you do a thorough cleaning, you should be good to go for the next case. One important thing is that even in the OT, if for a COVID positive case, if you have done some aerosol generating procedure, for example, if you've done intubation of the patient, ideally you should close the door of the OT for 20 minutes and then only go for cleaning of the OT. That is preferred because, you know, evidences are coming for airborne mode of transmission for COVID-19, though again, it's not confirmed as of now, but yes, with the rising evidences, that's what is recommended. So when you clean, again, the direction of cleaning has to be from clean to dirty, top to down. That means when you're cleaning, you clean the cleaner area first, you know, the away area first, and the instruments or equipments just around the OT table are the more dirtier area. So you go from clean, that is outside, towards inwards, top to down. Right? Next slide, please. And that's how you clean the floor of the OT also, from outside towards OT table. Right? Certain IPC guidelines for OT, as I could gather from Indian Society for Anesthesiologists, that, you know, central air condition and the circulating one, you know, because if the AC is connected for 2 to 3 rooms, that should not be used. It should be turned into a non-recirculating system if possible, right? Because if air is transmitted, if the AC is common for 2 to 3 rooms, it's
Sorry to interrupt, ma'am. Your time is over.
Yes. Shall I take another 2 minutes to conclude, please? Yeah. So preferably a negative pressure, if can be created, that can be created by putting exhaust fans, allowing only minimal number of people inside COVID OT. Next slide, please. I'm quickly finishing, Dr. Subi, don't worry. Another 1 minute. Next slide, please. And time should be given, enough time between 2 cases, so that there can be proper cleaning, then disinfection of the OT before the next case is taken. I must say, all the frequently touched surfaces, all the horizontal surfaces, two level of cleaning should be done, very, very important before you take up the next cleaning, right? And some of the recommended ones are, you know, vaporized hydrogen peroxide is also recommended, and try to use a linen which is disposable. Next slide, please. I think that's the last slide. And in labor room, I think a lot has been emphasized. If you're using fetal monitoring equipments or ultrasound equipment, they should be decontaminated after every use, and staff should be kept to a minimum. Yeah, I think that's the last slide. So with that, I finish my presentation. Thank you so much.
Thank you, Dr. Gulati. That was a very elaborative presentation, and I'm sure everybody must have benefited out of that. I'm glad to share that Dr. Prabha Chandra is back online.
Hello, everybody, and you know, I'm the last person in this talk, but every person in the today's talk has talked about mental health, and we realize the extreme importance of mental health in during COVID times. Now, one of the important things that people have mentioned is that there are 3 groups of people. One is women who are pregnant. The second is women who are pregnant with COVID infection, COVID-19 infection, and women who are in the postpartum period and have COVID-19 infection. So each person's reaction is going to be slightly different. And that is what I want to emphasize. I also want to emphasize that at any point that a woman meets you, it's extremely important for us to assess that person's, that woman's mental health. So like Dr. Aparna Sharma mentioned, how many times a woman can come. We usually say that once in the pregnancy and once in the postpartum period, minimum during COVID-19 pandemic, women should be assessed for anxiety as well as for depression. So when we talk about mental health, we talk a lot about depression, but not so much about anxiety. And what we have seen and what the evidence has shown from studies done in India as well as elsewhere is that anxiety seems to be a much bigger problem than only depression. So there are many reasons why a woman, thank you very much for the slide. So I can go to the next slide, please. I want to basically start with some of the case examples. So can I have the next slide? Possible? So what happens is that when a woman wants to get pregnant, they often plan this pregnancy, and they don't expect that something very untoward is going to happen. So I'm going to tell you these 3 stories of women who actually came to us for you to understand what kind of mental health issues can happen. So this is 31-year-old Supriya, and she's a nurse who is currently 4 months pregnant. She had an NTP in the last pregnancy because the fetus had a heart condition. So she's extremely, no, the previous slide, please don't change the slide. Please go to slide number 2. Please go back to slide number 2. I'm seeing slide number 3. Please go back to slide number 2. So, please go back to slide number 2.
Ma'am, do you want the
so
stories?
I think the important thing is yeah, I want the stories, please.
Story slide is visible to everyone.
So, okay, to me, I think this previous slide is visible, so that's the reason. So I think if you see the story slide, you'll realize that these women, this 31-year-old Supriya, who's a nurse who's currently 4 months pregnant. She had an NTP in the last pregnancy because of a fetal heart condition. So she's very anxious that this baby should also not be affected. And she's already 31, so she's extremely anxious. The time is running out. A patient of hers turned COVID positive and her anxiety escalated. So a lot of, I'm specifically mentioning this because I'm talking to a lot of health professionals who may also, many of you may also have had pregnancy, may be planning to become pregnant. And we, tend to ignore the plight of health professionals who are, struggling. So then I have 27-year-old Meena, who's owned a school and planned a pregnancy because she thought she had enough income to manage a second baby. But now the school is shut. So she's in financial crisis. She's in her 8th month of pregnancy, unable to sleep, feels extremely depressed and occasionally suicidal. Finally, we have 25-year-old Padma. We also heard how in the past the guidelines about women being COVID positive and rooming in were not very clear. So this happened in in the first wave, where she was detected to be COVID-19 positive. Many times women who are positive do not stay where they have registered in the ANC. They have to be taken to another hospital. So she was removed, abruptly taken away in an ambulance, was alone after a C-section. There was no birthing companion. Her baby was kept in the nursery and she was not allowed to breastfeed. So we know that these things happened in the past. They're not happening so much now. But I just want to emphasize the kind of things that can happen in, when things like this go on. So these are some stories which tell you what the problems are. I want to go to the next slide, which talks about perinatal anxiety and depression. Now, perinatal anxiety basically, so can we have the next slide? Perinatal anxiety usually happens when, there is fear related to the next slide, please. Yeah. Can I have the next slide? May I have the next slide, please?
Ma'am, you want the perinatal anxiety slide that is visualized in everybody's system.
Yes.
Everybody
Yeah.
can see.
Okay, it's visualized. Okay. So perinatal anxiety and depression is fear related to the virus and disease and death, because people are listening to a lot of morbidity and mortality which is happening. So it's quite, see, we must remember that in pregnancy, anxiety is quite common. And in fact, it is useful to be anxious because a little bit of anxiety helps the mother to protect the baby, to protect herself. So we don't worry about optimal anxiety. But now during COVID, we find that the anxiety levels are very high. And many women, we heard very nicely today about what is the risk to the fetus, what is the risk to the pregnancy, that the pregnancy itself may not really be a harmful thing. But then a lot of people in the public don't know enough about it. And women don't have enough information. Doctors and nurses have information, but patients and women do not have information. Social isolation. A lot of pregnant women have said that this is the time they would like to go out, eat things, but they have not been able to do that. Many of the presenters also mentioned the role of social relationship conflict and partner violence or domestic violence. We see that pregnant women, even normally, if you look at the NFHS data or any other data, rates of violence during pregnancy have ranged from 7 to 10%. We found that during this time, the rates of violence increased because women were together with their, the perpetrator inside the house. Many women had financial insecurity, like I gave you the example, and some women had food insecurity, were not very sure about their nutrition because husbands had lost their job, and some of them had housing insecurity. So I think when you're pregnant, these sudden changes that have happened in their lives were causing a lot of mental health problems. The next slide, please. So my next slide is about trauma and psychological injury. And one of the things that is happening in COVID-19 is trauma. And you must have heard a lot about this. Now, what is trauma? Trauma in Hindi we call sadma. Basically an event which is very difficult to handle, which is sudden, which overwhelms you. So several women were not being accepted in hospitals that look after patients with COVID infection. So many hospitals became COVID hospitals. So there was no clarity about, is this a COVID hospital? Can I go here or not? Most women were going to hospitals where they were already registered. They had a rapport with the obstetrician, with the A&M, but then they were asked to go to another hospital. Some women have reported that there was perceived lack of care during labor. I think this is also because, especially if they were COVID positive, the guidelines were probably not as clear as they are now. And many health professionals were also very scared. So that is the reason. Not having a birthing companion, lack of transport during lockdown. Now that is something which worries a lot of people, because ambulances, as you know, we have good government ambulances, but they're all overwhelmed right now. And many times what is happening is people, if they're in the rural area or it's a high-risk pregnancy, there is a lot of anxiety. Will I get transport? Perceived lack of empathy from healthcare professionals who are themselves burnt out. And I think this is a very important aspect, which I think as health professionals, you'll all realize that we are all overwhelmed with multiple responsibilities. We are worried about our security. We are working overtime. There are forms to fill. There are, women need more help from us. Families need more help from us. Our children need more help from us. So many times we may not have the kind of empathy that patients are expecting from us. So that is also causing trauma and psychological injury and adding to the concern. The next slide. So one of the things that the next slide is on COVID-19 related trauma and who is at risk for post-traumatic stress disorder. So now many people are talking about how post-traumatic stress disorder is a condition that is going to be even more than anxiety and depression in pregnancy and postpartum. What is post-traumatic stress disorder? It is a condition where you keep reliving the trauma. So if a woman has had a bad experience, she's not been able to go, to hospital, she suddenly found out that she had COVID-19 infection, that can cause a certain degree of trauma. So women with previous pregnancy loss, like I had mentioned, women with a past history of a mental health problem. I think this is a very important risk group. So when we are looking at history, we should always check whether this woman has had depression in the past or she's had anxiety in the past. Women who had COVID-19 infection, and especially if the obstetric care was perceived as traumatic, delay of obstetric care near childbirth. And another very important thing that many of the speakers mentioned, and we need to pay attention, is bonding problems due to fear of transmitting infection. Now, most mothers want to hold their babies close to them, breastfeed them without anxiety, touch the babies. And this mother-infant bonding is an extremely important part for the infant as well as the mother's own mental health. Now, we heard that the baby should be 6 feet away from the mother if the mother has COVID infection. She should wear a mask when she's breastfeeding. Now, what happens is that as a result, we have found that mothers are having bonding problems because they have so much anxiety about touching the baby. feeding the baby, and many women are saying that we'd rather not lactate the baby. So these are, I think, mental health issues that we need to be cautious about. Good education and information, like you got a lot of information today. I think women need to get a lot of information. After the program, I will share certain leaflets that we have developed for women to manage their mental health, and we have it in different languages. So we can give this to the women so that they have information available to them. When they come to the hospital, when they're in labor, they may not be able to capture all this information, what you're giving them. So it's very important for us to give them some written information. So next slide, please. How will we know if anxiety is normal or excessive? So I think it's very important for us to identify, is this normal anxiety or is this more? So one way, and this is true for anybody, not being able to stop or control worrying about getting infection, even when all precautions are being taken, unable to switch off worries while trying to fall asleep. So keep thinking of the same thing again and again, unable to control checking social media messages about COVID. So because that becomes like a pattern, either of reassurance or constantly looking for information, getting extremely anxious about infection control procedures in family members. So when it is excessive, that is when we have to be worried. The next slide, please. Not being able to, so the next slide is about being angry. So feeling sad and angry because of isolation, feeling nervous, anxious, or on edge, not able to relax at all, being so restless that it's hard to sit still, becoming irritable, feeling afraid as if something awful might happen. And many women now, pregnant women, are getting sudden episodes of panic, where you may experience racing heartbeat, trouble breathing, tingling and numbness, feeling like you're not getting enough air, feeling trapped and wanting to escape. Now, this is not only women with COVID infection, but even other pregnant women are getting these, and postpartum women. And many times they confuse these symptoms for, let's say, breathlessness or heart attack, and they want to rush to the hospital. So it's extremely important for us to remember that these can be signs of a mental health problem. So what can we do to help our mothers not become excessively anxious? I think the most important thing is to ask them to share distress, talk to other people about what is going on with them rather than constantly brooding about it inside. Planning and preparation. This is extremely important in today's time, that any time somebody can become COVID positive, any time you may have to go into the hospital. So having a good care plan, which has been discussed with the obstetrician, if I become COVID positive, if something happens, then what will happen is very important. I will tell you some ways of decreasing anxious thoughts and finding ways of calming oneself. So the next slide. The next slide is a way of calming oneself, and this is true for everybody, be it pregnant women or not. And one is we always talk about naming the core worry. Now, what happens is when there are too many worries, we are constantly confusing everything. We are not able to name what it is. So I think it's very important. Is it about the delivery? Is it about the baby's health? Is it about your husband's job? Is it about who will come to support after the baby? Because now we know that people are not, lockdown is there, elderly people are not coming, everybody is not being vaccinated. So what happens is that the mothers may be worrying about 5-10 things, and they don't know what they're worrying about, so it becomes too much for them to manage. So we usually ask them, can you name what those worries are? So if you have 5 worries, can you tell us what is worrying the most? Let us try and solve that problem. So naming the worry and trying to use a problem solving approach helps the mother in calming down. We also, next slide, we also talk about avoiding to fuel your worry. So what is fueling the worry? That is adding petrol to the existing fires. If a woman is already anxious, already worried, it's very important to keep in moderation how much you talk about the problem and how much you're exposed to social media posts or TV. Now, what we say is don't completely avoid it. Because if you completely avoid information, then suddenly when something happens, you're not able to manage it. So finding a balance between exposure to information and calming period. So see something, talk to people, find out more. But when you realize that it is becoming too much for you, when your heart starts beating more, when you're constantly thinking about it, think that you have to have a calming period. Health professionals should ask about anxiety and provide support, including referral to mental health professionals. At the end of my presentation, I will give you a helpline number and we can circulate this to the ministry also. NIMHANS has a perinatal specified exclusive 24/7 perinatal mental health helpline number. So health professionals can call us as well as women can call us if they are pregnant or postpartum and talk to us and get support for their problem. So next slide, what are the positive things we can do? We all know this, talking to somebody, identifying an activity that you enjoy so that you get immersed in it. It's extremely important to use different parts of your brain rather than using only one part of the brain, which is the amygdala, which is the fear center. So when we are anxious, we are using only one part of our brain. It's extremely important to use other parts of the brain, like using soothing music, chanting, laughing and sharing, talking to other kids, reading, writing a gratitude journal, listing all the things that you're thankful for. These are things that you can do. And I think one of the things that we emphasize, next slide, is about what we call relaxing and mindfulness. Simple methods like square breathing. This is called square breathing. It is easier for mothers to understand. See, normally when you say do pranayam, some women may be able to do it, some women may not be able to do it. Somebody who's doing it earlier can do it. So what we usually say is this is called square breathing, and it really brings down anxiety. It can be used during your labor room also, when the mother is postpartum also. So this is a simple method of breathing in for 4 seconds, holding it for 4 seconds, breathing out for 4 seconds like you're blowing a candle, and then again holding for 4 seconds. It has been seen that by breathing, autonomic arousal comes down. The moment autonomic arousal comes down, the mind also becomes calmer and you're able to think clearly. So these are simple methods. If you think that the woman is extremely anxious or is depressed or is suicidal or has had a past history, then it is very important for you to reach out to a mental health professional. In most districts in the country now, we have the district mental health program. So please reach out to your DMHP team. Finally, I want to also talk about my last slide is about stress in health professionals. There is anxiety of passing on infection to older family members or children, of getting the infection yourself, of being away from support system, not sometimes being supported adequately by management, especially if you have to take leave because you're positive, financial problems. So I think very important, if we want to look after the mental health of pregnant women and postpartum women, very important for us to look after our own mental health. And again, the Ministry of Health and Family Welfare has a dedicated psychosocial helpline, toll-free, with a number 5 in it for health professional stress. So please use that and try and get supported. I think health systems who are managers, who we are superiors, it's extremely important for us to value the work that health professionals are doing. We should be responsive to their needs. They should feel that they are being heard, and they should also have a care plan if they are infected or in quarantine. My final slide, this is the NIMHANS Perinatal Mental Health Helpline. This is a mobile number. Please note it down and I will circulate it later. You can call it 24/7. There are several languages that people can speak. Predominantly Hindi and English, but there are other languages also if necessary. Anytime a health professional wants any support for mental health for a pregnant woman or postpartum women, they don't know what to do, what medicines to give, please give us a call. Also share this with women who are pregnant or postpartum. Please give us a call and we'll be very happy to support you. Thank you very much.
Thank you very much, ma'am. Now we move on to our question and answer session. We have plethora of questions. I mean, we have n number of questions right now with us. We've just picked and chosen 1 or 2 questions for each of the panelists. And in the interest of time, I will not waste time and move forward. So one of the questions that we have is what precautions are to be taken for a pregnant woman whose spouse or a close relative at home has been tested positive or is a suspect? I feel Dr. Anushri Patil, ma'am, if you could answer this question. Dr. Anushri Patil? Yes, ma'am, we can hear you.
Yeah. So if a close person or a spouse is tested positive for COVID, then that person should follow all the due precautions which are required in cases of COVID positive, like all the precautions for home isolation, isolating in a separate room, using separate utensils, and the pregnant woman, if possible, she can be quarantined to a separate place if it is feasible, or in the home. We should follow all the other precautions as well as wearing the mask, social distancing, and other things.
The next question I think is directed towards Dr. Poonam ma'am. Where should a triage area be developed if it is not pre-existing? Dr. Poonam ma'am?
Yes, thank you, Surabhi, for that question. And probably everybody wants to know that. You see, we have very congested maternity areas, but yet we have to find out a place which is very close to the gate, so that from the gate, as the patient enters, directly patient goes to the triage area. Now, these triage area can be constructed by, using those aluminum partitions or sort of in such an area where you can have an examination room and you can have your sitting area where the nurse sits and talks to the women. If you look into past few decades, Government of India have been repeatedly talking about the obstetric triages, and many places these obstetric triages have been developed. These are the casualties, emergency departments which were there in every institution. So no, those areas can be converted into triage. All what you have to see is that the distancing should be there and the examination area should be very protected, because it cares for the dignity of the women and looking into her privacy. So this is what exactly has been suggested, that wherever you have entrance, just close to that entrance, whatever area you can find, you can make a time shift arrangement and create a triage so as you can prevent your women to have COVID.
Thank you very much, ma'am. We have lots of questions on the safe drugs that can be administered to the pregnant women. However, I feel that Dr. Aparna Sharma's presentation quite covered that very nicely. But there's another question, Dr. Aparna Sharma. If a woman missed her ultrasound appointment due to being COVID positive, what should she do? Over to you, ma'am.
Dr. Surabhi, in case Dr. Aparna is not there, I would like to answer. You see, there are a few things which we need to know. When we do sonography, there are 3 sonographies which we recommend. One is that it has to be a dating scan, and now we are saying that NT scan and dating scan should be one, because it's difficult for her to come twice in the first trimester. So that NT scan has become mandatory. The second one is during the target scan, which we do in India before 20 weeks, and then we go for growth scan. Now, what is very important is you can miss many, but you should not try to miss the target scan, because that is the scan which will decide whether you need to have a medical termination of pregnancy or you can continue pregnancy. Even if the growth scan has been missed, a simple clinical examination can give you a lot of idea. But it is what we are focusing more is that no doctor should not see the patient and not do the target scan, because many cases what are coming with congenital abnormalities at the age of 26-week gestation, or where you cannot terminate the pregnancy, because MTP law of 22 to 24 weeks has come right now. So this is what we recommend, that no doctor and no patient should miss the targets.
Yes, ma'am. Thank you very much. We have another question. I think it goes to Dr. Manju Puri. Should a healthcare provider or a healthcare worker who has just delivered or just operated on a COVID positive pregnant woman, should that healthcare provider be quarantined?
Yeah. Thank you, Surbi, for that question. I think it was more of a problem in the first wave than what it is in the second wave, because that time, anytime a patient would come positive, everyone would be quarantined. So here now we expect most of the healthcare workers to be vaccinated and also to be using appropriate PPE according to what the recommendations are. So basically no quarantine to be required. The people who have been around that patient or who've delivered or who've kind of operated upon that patient need to be monitoring their own symptoms, their temperature and whether they are getting any symptoms or not, and also to be aware whether there was any breach, at the time of while handling that patient, was there any breach? I'm saying whether they were not actually wearing appropriate PPE. So those are the situations where they need to get tested. So there's we expect everyone to be in appropriate PPE. We expect everyone to be vaccinated. So we would want them to be monitoring themselves. And then there is no need for them to get tested in case they do not have any symptoms. So that is what is the recommendation which is being followed now. In case there is a breach, then they get tested themselves between 5 to 7 days. And I don't think so there is any reason for them to be quarantined. Yeah. So they will use all appropriate precautions and work.
Thank you, ma'am. We have one question on infection prevention and control. So, Dr. Bhavna, in places where there is only one maternity OT available, after doing a COVID positive LSCS, can we reuse that theatre after fogging? And should the routine fogging protocol be followed, or is there anything different? Dr. Bhavna?
Yes, Dr. Surbi. In fact, I have answered this question. Someone has written to me privately on chat box, and I was answering that also. See, I mentioned that on my presentation also. If there is one maternity OT and there has been a positive case which was operated, cleaning by 2-step is very, very crucial, detergent and water, and then followed by disinfection with 1% sodium hypochlorite solution of all the horizontal surfaces, frequently touched surfaces. And yes, okay, if the organization has been doing fogging with regularly, that can be done. Fogging itself is a, where guidelines are divided with that view. But yes, if you've been doing fogging, then yes, fogging can be done after this 2-step of cleaning and disinfection, and then you can keep the OT closed minimum for 1 hour. If possible for 1 day, if not, minimum for 1 hour, and then you'll be good to go.
Thank you, Dr. Gulati. One question we will specifically pick up in the arena of mental health. Dr. Prabha Chandra, there's a question that what is the more common problem in perinatal women with COVID-19? Is it depression or is it anxiety?
From what we have seen in the postpartum period, it is more depression. The rates of depression, like many of the presenters had mentioned, they have found that it is to be higher. But in the antenatal period, if a woman is pregnant and becomes COVID infected, then we find that the anxiety symptoms are higher. So just want to emphasize that there are several drugs which are, quite safe in pregnancy, and if the obstetrician can actually consult with the psychiatrist and start a low dose of an antidepressant, which is also useful for anxiety in the pregnancy, because that will actually bring down anxiety. And we know that high levels of anxiety are harmful to the fetus. In the postpartum period, depression is quite common. Again, lactation is very safe with many antidepressants. So if the woman has significant clinical depression, then she should be treated, because untreated depression has a more serious consequence than the medication itself.
Thank you very much, ma'am. I thank each and every guest speaker for this session for enthusiastically participating and being patient with us throughout if any of the technical glitches had happened. Now we move to the next session and the last leg of our webinar, where I call upon Dr. Bhumika Talwar to moderate the third session, which will be largely upon the experience sharing from the field. Please give us 5 minutes.
Good afternoon, everyone. The battle against COVID-19 across various states and districts is being led at the cutting edge by field level officials. While there is much to be gained by learning from global practices for tackling COVID-19, It is equally important to take note of practice that are grounded in our realities. Many of them have shown great initiative and come out with practical solutions. With this, we commence with the third technical session, which is on sharing of field experience in the management of COVID-19 in pregnancy. May I call upon our first speaker of third technical session, Dr. Padmaja, Joint Director Maternal Health Nodal Officer from Telangana, to share her experience pertaining to call center model for linking and referrals of pregnant women during the pandemic. Dr. Padmaja has completed 29 years in government service and has been handling the maternal health division in the state since 4 years. Over to you, ma'am.
Thank you, Bhu. So good afternoon, everyone, and thanks to Ministry of Health and Family Welfare, Maternal Health team for giving me this opportunity. And I also thank Dr. Poonam Kumar and Dr. Aparna Sharma and UNICEF for helping us developing COVID and training our gynecologists. After many interventions that we have been doing, one of the best practices is call center model for ambulance services. During our field visits and the feedback received from the districts and from the pregnant women, we understood that there was a apprehension among pregnant women to visit PHCs as they were conducting COVID-19 tests at the PHCs, and their lack of transportation due to lockdown also. And we have also observed that there is a drop down in certain maternal health indicators, especially antenatal registrations from 98% in April to 86% in May. And first trimester registrations also dipped from 78% to 68%. And decrease in 4 antenatal checkups from 75% to 66%. Next slide. So we are optimally utilizing this call center model to ensure uninterrupted antenatal and delivery services to the pregnant women. And we this call center model, so 102 call center and ambulance services 102 and 108 are run by GVK EMRI, and they have a hotspot generating software which is linked to the caller's data and arrives at the best location to place the ambulance and to reach the caller at the lowest possible response time. So through KCR kit, our state, we are pushing the data to this call center, and they will make the calls to the pregnant women and links them to the 102 vehicle for ANC and 108 for delivery services. So here you can see the antenatal list and the ANC due list and EDD data will be shared with the 102 call center, and that these call center they will get the inbound and outbound calls also. Inbound calls from ASHA, ANM and pregnant women and their family members, and outbound calls the 102 call center they will make these calls to the pregnant women to get their their due checkups, and they will motivate them for the delivery by utilizing these 102 and 108 services. Next. So the due list of antenatal and delivery and immunization list will be shared with the GVK EMRI call center, and 102 call center will make the calls to these pregnant women for antenatal checkups and high-risk cases and deliveries and immunization. And the call center, as I have already explained, outbound calls and inbound calls they'll make, and call center also receives inbound calls. And further, medical officer and supervisors prepares route maps in coordination with the district coordinator 102, and the advanced tour plan will be prepared and for all these facilities, and all pregnant women due for delivery are tagged with the 108 and antenatal checkups 102. So there are 300 102 Ammavadi vehicles and 300 108 ambulances are at present giving their services to the pregnant women and delivery cases. Next. So we are utilizing the this call center for scheduling of visits to outreach sessions also. And we have during this pandemic, most of the PHCs are conducting COVID testing. So there is a fear of getting COVID. So most of the women, they are not going there. So we have planned this sub-center model antenatal checkups. And PHCs are and Anganwadi centers are closed due to VHND activities are closed because most of the frontline workers are involved in COVID activities, and they are doing fever surveys also. So we have planned this sub-center model, and 2 to 3 days in a week, these sub-center level ANCs are conducted. And one digital call center informs the pregnant woman about the sub-center level ANC, and ASHA mobilizes the pregnant woman from 2 to 3 sub-centers and one PHC, and they will be collected by the 102 ambulance for transportation. And the MCH supervisor is the key person here. She takes the adequate measures for ensuring privacy, seating arrangements, and availability of medicines. And we have identified one MCH supervisor for each PHC, and she will have the list of primary ANCs and high risk ANCs, and EDD list also will be available with her. And she will ensure that each one gets the benefit of this 102 vehicle. And COVID-19 norms, social distancing, sanitization, and everything will be maintained at these sessions. Next. So we are monitoring this 102 web-based monitoring. We have integrated this 102 services with KCR Kit portal, and we'll track the movement and beneficiary transfers. So if you want to track the vehicle, we can track, and we can see the location where the vehicle is placed. And web-based monitoring through dedicated IT tool, that is KCR Kit Telangana.government.in. Monitoring at the 4 levels it is done, and health secretary, state level we are monitoring, and district level they can DM and H1 program officer can monitor, and at the facility level medical officer and the supervisors can monitor. Alert dashboard in KCR Kit portal alerts us on missed ANCs, high risk cases, and birth planning and pendencies, among other indicators also. Next, please. So this is the tracking system which we are tracking it through KCR Kit portal. You can see that how many total vehicles are allotted to that district, and how many active vehicles are there, and how many trips they are doing per day, and how many beneficiaries they are benefited by utilizing this 102 vehicle. And every day we are tracking the system, and the location of the vehicle also we can trace it. Next slide. So after this call center model, when we in the month of April, there is 98% of the antenatal registrations, and we have observed a dip in antenatal registrations. After utilizing this call center, there is a 98% improvement, and first trimester registrations also there is improvement, and for antenatal checkups also we have seen the drastic improvement. Same thing we are continuing now also. Next slide. So we are not only utilizing this call center for 102, 108 ambulance services, we are also utilizing to assess the quality of ANC in our districts. So we have shared one district data, we have 3 months data with the call center, and they have called the pregnant women, 2,636 pregnant women whose EDT is in November, December, and January. They have called them, and they have shared the data with us. Next slide. So these ANC services, trimester wise, first trimester registrations 81%, second trimester 7%, and third trimester registrations 1%, and details not available are 11%. So the first contact pregnant women, 61% of the pregnant women they are contacting this ASHA and ANM. Next slide, please. This is the data, how many of them they have investigated in first trimester. They are 64%. Seen by doctor is 85%. Seen by staff nurse is 7%, and seen by A&M is 8%. So the feedback given by the antenatals, pregnant women, our quality of services are good for 95%. Next slide. For third and fourth ANC done in 65% of the people, and accompanied by ASHA 86%. Next slide, please. Transportation 102, 108, they have utilized 65%. Own transportation, they are by 30% of the people. Rescheduled visits are 4%, and call issues not connected or other things are 1%. Next slide, please. So in the answered calls of 2,636, abortions were 61, and deliveries were 715. Yet to be delivered are 1,860. Next slide, please. So follow-up of the pregnant women and capturing of correct mobile numbers is very difficult, and most of the ANMs, whatever number is available, they are entering it into the KCR kit portal. So if correct number is there, means we can get the successful calls. Next is transportation should be flexible, as the EDD may change, wrong LMP and other things. Due to that, the EDD may change. So that the arrangement of a transportation should be flexible to this. And call center can be a medium of information to pregnant women in terms generating awareness on maternal health services and utilization of 102, 108, and ambulance for transportation for accessing antenatal delivery and immunization services also. Thank you.
Thank you, ma'am, for sharing your experience. I hope that this will be helpful for the other states also. The Government of India is committed for providing equal access to quality care to all, and digital health is a critical enabler for the overall transformation of the health system. Hence, mainstreaming telemedicine in health system will minimize inequity and barrier to access. On this background, I would like to invite our next speaker, Dr. Inderjeet Kaur, State Maternal Health Nodal Officer from Punjab, to enlighten us with her experience on teleconsultation for ANC services during COVID-19 pandemic. Over to you, ma'am.
Thank you so much, Bhumika. Very good afternoon to all my seniors in Ministry of Health and Family Welfare, and a very special thanks to Maternal Health Division for organizing this session. My topic of talk today is teleconsultation services for ANC during COVID-19 pandemic. Next slide, please. Next slide, please. Yeah, what was the need for teleconsultation services for ANC during COVID-19 pandemic? Actually, Punjab was the first state in India to have announced the curfew in the month of March 2020 to contain the spread of virus in the state. So there were restrictions for accessing the basic essential health services, especially those related to pregnant women and children due to curfew and lockdown. So the need was felt to start the alternative methods of consultation. Hence, in March 2020, state started the teleconsultation services at health and wellness centers through the teleconsultation hub. And in June 2020, state started eSanjeevani online OPD for gynecological services. Next slide, please. So at state, we are providing the teleconsultation services through teleconsultation hub, which is being managed by the medical officers and community health officers. And one is through the eSanjeevani Gynae OPD, in which the service providers are the gynecologists from the state. Next, please. Now, the telemedicine services at Health and Wellness Center. Telemedicine services were started at 400 Health and Wellness Center in month of March 2020. It is a hub and spoke model, and CDEX eSanjeevani telemedicine app has been developed. telemedicine hub hub is developed at the state, and medical officers are looking after that hub. And as a spoke, we are having our community health officers, which are as the spokes, and they are present at the health and wellness centers. And our target population is the rural beneficiaries through CHOs and health and wellness centers. Next slide, please. So regarding the telemedicine hub, it was established at the state headquarters with the following staff: the 5 medical officers and 1 telemedicine executive. Of late, we have increased the capacity in the telemedicine hub as our teleconsultations are increasing. And the medical officers were given almost 1 month training for the gynae in the Department of Gynae at a district hospital. Next, please. For the eSanjeevani Gynae online OPD, the aim was to ensure the uninterrupted health services to the public of Punjab due to wake of COVID-19 pandemic. So to provide the specialized healthcare services to pregnant and lactating mothers in both rural areas and any isolated community pockets, eSanjeevani Gynae online OPD was started. The timings are 8 a.m. to 2 p.m. in the summers, and in winters it is 9 a.m. to 3 p.m. So at state, the state team makes the duty roster for all the gynecologists with the help of the district nodal officers, who are nodal officers for eSanjeevani OPD, as well as they are the district family welfare officers. And the roster is shared with all the districts, and it is ensured that 2 gynecologists are present every day online for the gynae consultation during the requisite time. Next, please. So about 100 gynecologists were trained for eSanjeevani OPD services on the eSanjeevani platform for the protocols and for the functionality. And the technical support is being given by CDAC Punjab and Department of E-Governance Reforms. So with the help of CDAC and E-Governance Reforms, there is a dashboard has been developed, which is visible online, and we can see how many gynecologists are providing the services, the number of consultations that have been completed, and also if the gynecologist is not online, we immediately convey to the concerned district that to make the gynecologist online. And if there are any issues also regarding the OTP issues also, they are addressed with the help of CDAC. Thank you. Next slide, please. Now, this is the process of teleconsultation. At the patient's end, the patient has to do the registration and the token generation. So patient has to verify the mobile number using the OTP. Then patient has to fill the registration form and request for the token. And if the patient already has any sort of investigation or any health record, that can also be uploaded. And after that, the patient will receive the patient ID and token through an SMS. Then the patient will log in. Patient will wait for the SMS and notification to log in, because a particular patient ID will be created and that will be sent through the SMS. So when the patient will log in with the patient ID, and the patient will be shifted to the waiting room. So if the patient is, there are many patients waiting, the number will be reflected that you are on the 2nd or 3rd or 1st waiting. If there is no waiting, then immediately call now button will get activated and video call will be initiated. After the video call, patient and the doctor have face-to-face talk. The doctor will show up, patient can consult the doctor, and then patient can immediately get the e-prescription. Next slide, please. Antenatal care through telemedicine hub and eSanjeevani Gynae OPD. So far, from last year, March 2020 to 21, around 12,782 pregnant women have been received antenatal care through the consultation at health and wellness care centers. For eSanjeevani OPD, in the month of June, we were not getting the separate data. It was a mixed data with the general OPD, and from July to March 2021, around 250 pregnant women have received the services from gynecologists through eSanjeevani Gynae online OPD. And from the last 2 months in April and May, our OPD services have seen a lot of increase, which will be reflecting in the next data, because the second wave of COVID is much more severe, and women are endangered getting out of their houses, and they're preferring the telemedicine. Next slide, please. Now, the tracking of high-risk pregnancy. This also we started around 3 months back, when we saw that because of decrease in the physical contact, the patients are facing the issues. The high-risk pregnancy identification was started by the through the community health officers. They are being registered at the telemedicine hub by the teleconsultation or by eSanjeevani, and or by WhatsApp whenever they are not able to access the eSanjeevani. Around in last 3 months time, we have around 2,157 high-risk pregnant women that have registered at the telemedicine hub during these months. Next slide, please. Now, what are the benefits of teleconsultation services? First and foremost is to avoid the spread of disease. As everybody has been telling since morning that the second wave is much more severe and virulence of virus is too much. So in order to avoid the rush at the hospitals in wake of COVID-19 and contain the spread of virus by receiving the care virtually, patient will not have to visit the hospital unnecessarily. It also helps to save the time spent in the waiting room or in the common areas in which the patient is so much exposed to the COVID virus. Then patient no longer has to go to the healthcare centers or to be treated by a doctor to control the chronic diseases unless it is direly necessary, then only should the patient visit the hospital. Then is the saving the time. If there are no excuses to postpone any medical consultation, so it will be enough to request an appointment by a phone or online to be attended by a specialist. This is an early, this helps in an early diagnosis of the disease and timely treatment to control any pathology. Then is the accessibility. So since India is becoming more and more digital, almost everybody is having the access to the smartphone. So the accessibility and access to the teleconsultation services through a mobile phone or laptop is very readily available. Prevent the self-diagnosis. As more and more people are turning to the internet or to the Google to treat their symptoms, they keep on searching. This habit not only leads to complication and their clinical condition also worsens, but it also puts in their life at risk. So thanks to teleconsultation services, patients can receive the advice from a healthcare professional quickly and effectively. Next slide, please. What are the challenges in providing teleconsultations? Like internet connectivity, it is a major hindrance, especially in the rural areas, far-flung areas where connectivity is not very good. So second one is the technical issues. Sometimes due to eSanjeevani OPD being a very high load of patients is there, a lot of patients are waiting and sometimes server is down. Sometimes there are issues with the OTP generation. OTP is not generated at times. So these are the technical issues that are looked after. And patient related is that many patients may find the process difficult. That is why we have the more consultations through the telemedicine hub by the CHOs, which is a more simplified form. At eSanjeevani, sometimes the patient finds it difficult to get the OTP and then log in. And in doctor-patient relationship, a patient may not get to consult the same doctor in the second consultation. Suppose once he has consulted a doctor or a gynecologist, she wants the same. It is not possible because duty roster is fixed and doctors keep on changing. It also affects the patient and doctor relationship negatively. Then follow up. Whatever treatment doctor has given, whatever treatment that gynecologist has given, what is the compliance of that treatment? It is difficult to follow because patient is not physically visiting the doctor. So we have to develop some mechanism regarding the follow up of this teleconsultation. And then is the quality of care provided. We cannot provide 100% accurate quality of care through teleconsultation because sometimes only on the physical examination can we point out the certain diseases which may lead to a delay in diagnosis. Next slide, please. So these are the doctors, they are providing eSanjeevani, Gynae OPD, they are online and you can see that a doctor and patient is having face-to-face consultation. They can ask about the symptoms and doctor can then further advise and immediately write an e-prescription. Here is our gynecologist who is providing these services. Next slide, please. Now, what is the way forward? Way forward is that appointment of gynecologist at the telemedicine hub. Although we have made strengthened the telemedicine hub than before, we are further trying to post 2 or 3 gynecologists at the telemedicine hub. Another plan with the state is that we want to merge the eSanjeevani Gynae OPD with the teleconsultation services at Health and Wellness Center because we are having medical officers at Health and Wellness Center. So for the specialist advice, we want to create some sort of linkage with the eSanjeevani Gynae OPD. And next that state is planning is because of the COVID pandemic, it is very difficult for the patients at times to reach. And in the second wave, we have seen that if one person is infected, almost all family is infected. So we are planning for having a delivery of door-to-door medicines and hygiene kits in a box form to all the pregnant women. The form we have designed is the Mata Tripta kits, and we are planning to launch these kits very soon. This kit will contain some nutritious food packets with a longer shelf life of maybe 6 months, something like panjiri or some protein biscuits kind of thing. And it will also contain a hygiene pack for it will contain masks and sanitizers and some IEC material for the patient. And it will also contain a medicine pack for pregnant women, which will contain basic our iron, calcium, multivitamin, and paracetamol. Thank you very much. That is the end of the presentation.
Thank you, ma'am, for sharing your experience and the detailed presentation. Next, we have Dr. Archana Mishra, Deputy Director, Maternal Health, Nodal Officer from Madhya Pradesh. Dr. Archana has been part of many expert group committees of Maternal Health Division and has contributed to innumerable maternal health guidelines. I request ma'am to share her state experience on data analysis of Integrated Command and Control Center during the pandemic. Over to you, ma'am.
Thank you, Sobi. Bhumika, can you please share the presentation, please?
Yes, ma'am.
At the outset, I would like to thank Sigdar sir and Dr. Padmini and the entire maternal health team at ministry level for organizing such an informative webinar. And in fact, all our doubts have been cleared by the eminent panel of our experts. And we had been able to listen to the presentation of two colleagues from Telangana and Punjab, and both have been replicable models. And we'd like to have more details offline. Now, my presentation is on Integrated Command Control Center and Suman Help Desk. This has been sanctioned in our ROP for this year. And how we have utilized this command control center and Suman Help Desk during this COVID pandemic. I'll be sharing a brief outline. I'll be trying to be as brief as possible. Next, please. The objectives of the state level integrated command control center. This has been established for follow-up of maternal newborn child health services and also the conditional cash transfer schemes. We have Janani Suraksha Yojana and a state-specific Prasuti Sahayata Yojana, and these are being followed through RCH portal. We have modified the RCH portal of ministry by making it a bit state-specific and adding the management part also, like in the severely anemic women, how many women have been given the blood transfusion or iron sucrose in moderately anemic women, and some other high-risk factors we have added into it, and we have made it a community module and a facility module, and it's linked to delivery module also. And the linkages with referral transport system as highlighted by my colleague from Telangana, it's in the way forward. It's not yet started, but in the planning phase, it is there. And developing the mechanism for addressing the grievances by linking it with 104 toll-free number, 100% reporting and follow-up of maternal and infant deaths, which has been always a channel for Madhya Pradesh, because only we are able to capture the information and line listing of 50% of the deaths, and evidence-based planning based on the findings of the command control center and also the data from RCH portal. Next, please. This is the structure of Integrated Command Control Center. It is headed at government level by Additional Chief Secretary Health. The administrative control is with Health Commissioner, because we need to address to the grievances, and in some cases the action has to be taken from state level also. At the execution level, mission director leads this center, followed by implementation level program officer, maternal health, child health, and referral transport. The child health part, except for SNCU follow-up, has not yet started because we've just crossed the neonatal period of ICCC. So there are lots to learn more, and we'll be sharing in the future course of time what challenges we are facing and what benefits we have actually gathered from implementation of ICCC. Under this, I was trying to explain this flow diagram. The state level command control center, we have a chief of executive officer. It's a private vendor. There are 3 supervisors which works in each shift, because this command control center is 24/7. There are telecallers who works in 2 shifts. 15-seater command center is there, so 15 telecallers are in the morning and 15 are there in the evening, and 2 are put in the night hours if some incoming calls are there. Incoming calls are not yet started because the 104 is handling with the calls of COVID. So all the calls are related to COVID, and so this number at present is not free, but by the end of this month we'll be getting this number for grievances and incoming calls. Then at district hospitals and medical colleges, all the government medical college, we have Suman Help Desk. It is being established at maternity wing of district hospital and medical colleges, and we have 1 supervisor and a data entry operator or who is manning the district Suman Help Desk. Next, please. May I have the next slide? How did we go about for establishment of ICCC? Actually, we floated a RFP with terms and conditions for bidding, like those with experience of running a call center and with some financial credibility applied. And there were 4 vendors, and the vendor with the lowest bidding cost, and the criteria for financial bidding was kept on per seat telecaller cost, like per desk. If we have 15 seats, so they each of the vendor had bidded for per seat cost, and those with lowest was selected. And recently it has been inaugurated by Honorable Chief Minister on 27th March. After that, there was Holi, and on practically, if we see, it started from 1st April 2021. And we have made a call calendar, and we shared the call calendar with the Chief Executive Officer of Command Control Center. It's We've called our organization, who was running our 104 CM helpline center also. So it has got ample amount of experience of handling the call center. So the calls, we share the call calendar with them, and from where to take out the data, phone numbers and all for calling. Like on Monday, all calls related to Jani Suraksha Yojana, Prasuti Sahayata Yojana, because at this time of pandemic, people are left with no jobs. So this conditional cash transfer schemes are very important so that they get the timely payment. So the district account managers are being called on Monday, and we tell them with the list that these are the women who delivered in your institution, and they have not received the payment. We share the list with them, and the telecallers make a call to them. And regarding maternal deaths, on every Monday, block program managers are being called just to gather the information, how many deaths have occurred in their block. We have shared the primary informant format of GOI, maternal death surveillance guidelines, and we collect the data from that. And district health officer, who is the nodal officer for maternal health, are being called on 1st and 3rd Monday regarding the number of severely anemic who have not received the services, number of ANC who are due for the services, number of maternal deaths, and the the women whose payments are pending for conditional cash transfers. Tuesdays, we make call to high-risk pregnant women. We have taken 4 high-risk categories: severe anemia, moderate anemia, PIH, and women with previous section, because the number becomes too large, especially in cases of moderate anemia. And we have developed a set of questionnaires, and I can share with you offline to the ministry, and it can you can also have a look at it. We call gynecologists for HRP clinics and PMSMA days, whether they are providing services or not, whether they are finding any difficulty, whether the women are being mobilized. Like currently we have asked our district team and block team to use 108 ambulances for mobilizing the clients, but the ANC checkups are being limited. So only the third trimester women are being mobilized. And again, on the Wednesday, call to beneficiaries are being made who are nearing EDD to ensure institutional delivery and to make them aware that all the services are flawlessly running in our institution and the services are free of cost. And Thursdays, we make call to poor performing ANMs who are not doing anything. And the criteria for selecting the ANMs is RCH portal entry. Friday, the child health calls are being made for tracking of SNCU discharged newborns. And Saturdays, to community health officers and sector medical officers for overdue services of high-risk women. And on Sundays, again, to high-risk beneficiaries of the four criteria which I mentioned. Next, please. This is the gist of the calls made in 1 month. Practically, as I mentioned, that is started from 1st April. And if we look at all the categories of call, nearly 44,500 calls were made, and 59% the calls were not connected. There were wrong numbers in 6.5% and 6.8% the calls were busy. And in remaining, the call was not picked up. So again, the challenge, as the telemedicine colleague was saying, that the phone numbers are not correct. So we are trying to rectify the numbers with the help of ANM. The numbers of CHOs and DPMs and DHO1 are correct, but probably the CHOs are engaged in vaccination work and field work, so they are not picking up the call. And DPMs also, they are currently not used to getting such calls. But we are trying to ensure that they pick up the call and listen to what we are saying. Next week, we have planned a meeting with MD also, so that things can be reviewed. Next, please. I think we have skipped 3-4 slides. District help desk. These are established at medical colleges and district hospitals in the maternity wing. There, the calls are being made by operators to ANMs of those women who ANM is supposed to take care, like severely anemic women. If the woman knows that she is severely anemic and she is registered in portal also, but still she has not received any services, then we are making calls to ANM to ensure the services are given to women. This is one of the examples. And weekly reporting of maternal deaths we get from the district level call center. The local grievances are being dealt at local level. And the one most important function of district women health desks is the women who are referred from periphery, from other delivery points to district hospital. They do a sort of facilitation, that it's a type of reception. The person, like in private hospital, a person is there to receive them through when they are coming through 108 ambulances or their own vehicle. They inform the gynecologist, they inform the blood bank officer if she has been referred as a high-risk case for sonography. The date is fixed, scheduled, so that during this COVID phase, she do not have to run here and there and go without getting the services. And also when the women is referred from district hospital or low-level facilities to medical colleges, so once woman health desk person informs medical college woman health desk, so that we ensure that the referral is assured and we do not waste time at reception area, and informing the service provider gets delayed. Next. We started first of all with ANMs, just to know that whether VHND sessions are being organized or not. But we were happy to see that in most of the districts, the response was good. In 90% of the district, the ANMs said that we are organizing VHSND, except in Bhopal that is marked in red. All the ANMs in Bhopal are being indulged in vaccination and field-to-field survey in COVID phase. So this has been suffering. Otherwise, more or less, the VHSND sessions are going on. Next. Next, please. Regarding availability of logistics, also the ANMs gave a response that 95% of them were having BP instrument at their VHSND site. They were using stethoscope and fetoscope for listening to the fetal heart sound, but 17% said that they do not have anything. So we are taking care of that because we have the line listing of the ANM who said that they do not have the equipment for listening to the fetal heart sound. And in aspirational district, we have provided them with fetal Doppler. So they responded that they are using fetal Doppler. Regarding the hemoglobin, this is the gray area. 60% of the ANM are using WHO color scale, though they are having Sally's hemoglobinometer also, but still they are using WHO color scale because our RC of digital hemoglobinometer is in process, and within a couple of months we'll be able to provide digital hemoglobinometer as per NIPI guidelines. The one thing which was encouraging is that they are having availability of IFA and calcium for distribution at beneficiary level. Next, please. For COVID appropriate behaviors, these calls were made randomly to women with no complications also, because most of the calls at state level were made to high-risk pregnant women. They were told about COVID appropriate behavior, but these calls were made in addition to the high-risk women, and they were told that under JSSK everything is free of cost. 108 is also available. They have to come to the hospital and get the services during their delivery time, and also for the ANC checkup, how they have to come and where they have to report. Next, please. This is the information which we were really actually alarmed to see, that the calls were made to severely anemic women, and when we asked them whether they got blood transfusion, and it was just alarming to see that the women in Ashok Nagar, Sihor, Neemuch, Anuppur and Vepul, they responded that the women were told that they were severely anemic, but they have not received any medication or blood transfusion. And more than 70% of the beneficiaries of few districts like Devas, Khandwa, and two of them are aspirational district also, they said that they received blood transfusion during the COVID phase also, because we have asked our blood bank officers to make calls to the donors and get adequate units of blood at the blood bank and blood storage unit. Next, please. This was a brief presentation and quite a lot to learn, but we have tried to monitor high-risk pregnant women, and this has been very helpful in this COVID pandemic phase also. Thank you so much.
Thank you, ma'am, for sharing the elaborative presentation. I really hope that your field experience will be replicated by the other states. Without further delay, may I like upon the last speaker, Dr. Tamkeen Khan, to share her experience from the labor room and the OT in Jain Medical College, Aligarh. Professor Khan has more than 28 years of teaching experience and has published papers in 100 index and peer review journals. Over to you, ma'am.
So before I begin, I would like to thank the respected officials from the Ministry of Health, Maternal Health Division, Dr. Sigdar, Dr. Padmini, and the team, especially Dr. Bhumika and Dr. Surbhi, who've been working so hard to make it successful, my all co-panelists and attendees. So we all know I'll be sharing my experiences and how we ensured that maternal health services could remain to be provided, and also how we tried to maintain the quality of the maternal health services. We all know the lockdown was announced on March 24. Next, please. The very next day, about 3 patients tested positive at Jain Medical College. Next. And it was not very difficult to envisage the state of maternal health or what would happen to maternal mortality because of this pandemic. In fact, the Lancet published a paper on 12th May predicting what would happen to maternal mortality and also the possible problems and some solutions. Next, please. So we started preparing ourselves. It is rightly said, by failing to prepare, you are preparing to fail. So next, please. The challenges before us were that we needed to prepare a dedicated COVID OT and labor room, rearrange work areas as per COVID requirements, rearrange duties of doctors and other healthcare workers. You needed a team for contact tracing and supporting healthcare staff. Then again, SOPs and protocols needed to be made for COVID and suspected COVID and non-COVID patients. We needed to retrain our healthcare workers from universal infection prevention practices to standard infection prevention practices in donning and doffing and biomedical waste management. And again, another task was arranging PPEs and other supplies during lockdown. And of course, we needed to continue teaching and training, examinations, thesis work. Next, please. The most important decision for us was to watch patient services to be continued. So we decided to continue with the emergency and the labor room 24/7, stop all elective surgeries except for oncology surgeries. IVF unit, we had a guideline to stop. OPDs were discontinued because of the risk of overcrowding and problems with infection control. But we were very sad about it because we know that about 85% of all complications in antenatal patients will occur in low risk cases. So it remained a challenge for us, and which we solved later on. Next, please. So we prepared our SOP the very next around 16th of April using baseline guidance from Ministry of Health, FIGO, and WHO. Next, please. And basically, we were dividing patients on the basis of a questionnaire which looked at symptoms, travel history, and area of their residence into COVIDs and non-COVIDs. Next, please. And managing into 2 areas. At the same time, we were one of the first departments to start a skeletal form of telemedicine by creating 2 hotlines, 929. And these here we were using all those staff who were being quarantined or who were stuck up because of the lockdown. Next, please. In order to reduce the workload and decongest other areas, we decided to have a detailed hospital admission policy and discharge policy. And we tried to manage all those cases which are normally admitted, like IUGR, GDM, PROM, monitoring for infection, placenta previa, or certain cases of missed abortion or hyperemesis. We tried to restrict the admissions and counsel the patients and monitor them on phone. At the same time, no admission was allowed without discussing with the senior resident on duty. We decided on early discharges, 48 hours for normal delivery, reduced to 24 hours, and from 96 hours for cesarean, we reduced to 48 hours. The woman was given, the lady was given, provided that helpline, and she could call us back and she could come back to us anytime. Next, please. So we utilize other paramedical staff to help us in screening, and that way we could do with less of doctors. Next, please. We tried to make it easy for the patient and provide care in a respectful manner. And because she had to go to a far-off building for fever clinic, to the fever clinic for the RT-PCR, so we arranged training our own staff in the labor room, near the labor room itself, and arranging PPEs and sanitizer was not much of a problem because we were allowed to order them according to our sizes, which made it much easy for us because of the support from the administration. Next, please. Putting together OT, COVID OT and labor room. Next, please. And retraining. Look at the expressions. I just put it here. This was in normal times, and look here, the somber and the tense expression on the healthcare workers who were supposed to enter the COVID wards because of the fear of the unknown. Next, please. The duty roster next were rearranged. Next, please. The online platforms came to our rescue for the morning reports and seminars. Next. And this is the first baby which was delivered in that COVID OT. Next, please. We thought We had arranged everything and we could rest. And the very next day, one of our JR3s working in the non-COVID areas tested positive. So that was May 2020. Next, please. The tracing of the contacts revealed that these were so many doctors were supposed to be the first contacts of that GR. Next, please. And on top of that, rearranging duties because of absenteeism or some actual, stress by the other healthcare workers, sending me pictures like this. Look here, madam, I have a barricaded road. I cannot come to duty. So all duty arrangements used to go haywire. Next, please. So we made it a policy that all patients will be considered as COVID positive unless proven otherwise. Next, please. And for that, we prepared the second protocol, which was prepared by 6th of May. Next, please. We rearranged the flow of patients right from the triage area. Next. And shifted the triage to a much larger area, utilizing the waiting area for the patients initially, which we were using. Next. So that the patients could be put at a distance from the doctors. Next, please. And again, we provided masks for the patients because they did not have enough money to procure those masks. So we requested one women's club to donate those masks for the patients and their attendants. Next, please. In June 2020, we had another problem. The reports were coming late and patients were reporting late to us and continuing to die. And we were utilizing an enormous amount of PPE kits, about 70 PPE kits per day in the OBG department at a rate of 1,000 per kit. Next, please. So these are some of the x-rays that I took for those patients because of they were reporting so late to our triage. So most of them were reporting as cases of pregnancy-induced hypertension, severe hypertension. Some of them are not even giving us 2 or 3 minutes for the resuscitation and dying. And just about 30% of them were COVID, came out to be COVID positive later on. Next, please. So the problem was how to provide antenatal care because some policy decision needed to be taken and some form of OPD services had to be provided so that we don't end up with this kind of patients coming to us. The problem was there was very limited staff and there was hardly any pace to run the OPD. Next, please. So we started that we will screen patients on phone with the help of a questionnaire by the supporting staff. They will send them a panel of investigations which will be reviewed on WhatsApp and then schedule the first visit around 20 weeks with their ultrasound report and then the next visit at 32 weeks. A de facto OPD was started at the triage itself and we were attending to more than 100 patients per day by June 2020. Next, please. We categorize work areas according to the risk involved. And we also started a QI project on rational use of PPE. And next, please. In the labor room, we decided that we could do with just simple gowns and the rest of the equipment or the HIV kits, whereas in HDU and ICU and the operation theaters, we were using full PPE kits. Next, please. At the same time, we started a centralized distribution of the PPE and maintain a stock register. And because there was some suspicion that pilferage was happening, we also started confirming it with the doffing record. Next, please. So we could decrease the use of PPE to less than 50 per day this way. Next, please. Now, another problem was that we thought of what happened to the respectful maternity care because we had stopped providing a birth companion in the labor room. And again, the problem continued of more doctors falling sick. Next, please. So this is what had happened to the run chart of our birth companion. Next, please. And we thought of then starting it again after counseling the patient's attendance and taking a written consent, informed consent. And this form was developed and we again allowed birth companion. Next. Another thing we decided was to decrease the workload on the doctors to limit the number of morning consultations from more than 100 to just 50 consultations. Next, please. So we tried to make a balance between providing appropriate care to the patient as well as taking care of the caregiver. Next, please. We thought we were doing very fine when next, please, the hospital infection committee sent me this, picture, and I thought my doffing area is looking like this, but she sent me this picture, and I was really, that was quite a setback. Next, please. So then we started. The sister on duty was given the responsibility of looking after the donning and doffing and sending 6 hourly pictures with each evening, each duty shift, because we were having 6 hourly duties with the PPE. Next. And this pictorial recording helped us in auditing and maintaining our standards. The problem in August was a long waiting time for COVID reports, overcrowding in COVID suspect area. Next, please. So we started the rapid point of care antigen testing, which used to decrease a lot of patient load in the COVID suspect area. Next, please, because they were shifted to the COVID ward proper. And then we also converted our OBD waiting area to another ward for suspected COVID patients. Next, please. Our experience with telemedicine, we had a very wonderful session right now, but we did it in a very skeleton form. We started as early. The lockdown was 24th. We started on 26th. Next, please. But look at because we were using no dedicated time, no dedicated equipment, and no trained person. So we started doing it on phone itself. So look at the quality of the reports, which we were supposed to decipher and read, and patients were not trained enough. They were sending at all wrong investigations, and we were supposed to, prescribe on that basis. Next, please. It was quite a challenge. Patient sending me, I'm advising one investigation, and an educated patient sending me 43 reports in return, which I'm supposed to read. Next, please. And then patients, they had a long language problem. This particular patient, I later found out, did not want to work in IVF, but wanted an IVF consultation. Next, please. Another patient sending me, frivolous requests like Haddi ward mein kaam chal raha hai ki nahi. Next, please. So the challenges were many. There was lack of smartphones, unable to type, poor net connectivity. For telemedicine to be successful, I found that all stakeholders should be trained. The patient also needs to be trained for telemedicine to be successful. And it can also decrease the patient load for us and help us reach underserved areas, even in non-COVID times, if we develop this particular ability right now. So why do we continue to do it? Next, please. Sometimes we have been able to recognize impending danger and prevent one of the greatest tragedies in medical practice by a preventable maternal death by guiding the patient in time through that WhatsApp calls. Next, please. This is our report card. The maternal mortality in 2019 was 87. It was in 2020, it was 119. Next, please. And you saw those x-rays, the patient hardly giving us any time to resuscitate them. So in the next, there were 7,861 deliveries in 2019, just 1,000 less in 2020 with an absolute lockdown for two months. Next, please. Next, please. The number of admissions we have been able to decrease by carefully choosing which patients need admission. And also, if we are, I was trying to go through the quality of care. So the number of complications in vaginal deliveries, just one slide I have taken, was not much increase, in spite of the fact that 1/3 of the staff was directed to the COVID area, and many of the staff were falling sick. Next, please. We have been providing the oncological surgery care to most of the patients, and there were 34 surgeries and 27 in COVID times. Next, please. So the take-home message is: plan, form a team, recognize each member's special talent, and delegate jobs accordingly. Optimize your resources, including human resources. Develop a fine balance between patient care and physician well-being. No plan is the best plan. You saw how every plan started going haywire. have a plan A, B, C, D ready, and QI principles work everywhere and all the time. Plan, do, study, act, adopt, or reject. If you have the passion, you can do it. Next, I handed over my charge as HOD, and this is my nursing staff. The system is still working. So I would advise everybody to work on the system, not on individuals. Whatever protocols we made, they are continuing, and we are continuing this seamless care for patients. Next, please. Thank you very much.
Thank you, ma'am, for sharing such a wonderful presentation. It is indeed an eye-opener. Now we are at the end of our last session. The panel is now open to questions. We have plethora of questions, so we have picked few questions. The one question is pertinent to Tamkeen Khan, ma'am. What has been your experience with respectful maternity care during the pandemic?
Yeah, I'm there. It's very difficult, when each doctor is suffering overpress, hard work, and suffering from personal tragedies. To provide respectful manner, it's very easy for me to talk about it. But once you have been sensitized or trained, it becomes a reflex with you. And that is the need of the hour. So because we have been sensitized to it, we already started Birth Companion, and we started as a QI project. We were able to, though there was some gap for some time, but we were able to continue it. So I think it's a reflex we need to maintain all the time, develop all the time, and in all the stakeholders, not just the doctors. The patient also has to be empowered to ask for respectful maternity care. So it does suffer when the doctor is stressed out or when the facility is overpressed, but it has to continue.
Thank you, ma'am. My next question is for Dr. Inderpreet, ma'am. What is the follow-up mechanism for a woman detected with high risk during teleconsultation?
Yes, yes, I'm there. We have a very planned follow-up for the pregnant women. The women who are being diagnosed as high-risk pregnancy at the teleconsultation hub. The community health officer of that hub informs the ASHA and ANM of that area, and that ASHA and ANM is going to then follow that high-risk pregnant woman and takes her for the regular follow-ups. Another thing that is ensured that the physical checkup of the pregnant woman is done at the CHC. Most of our CHCs are having gynecologists in place. So after the examination by the gynecologist, if the patient needs a secondary or a tertiary care, the patient is referred to that center. Otherwise, the patient is being taken care of that gynecologist. And then there is a tracking and regular follow-up mechanism also. And another thing that we are doing is that all the CHOs are sharing the list of all the high-risk pregnant women that they have diagnosed with the state level. And from the state, we have one or two our assistant officers and people from Health and Wellness Center who are randomly calling either the CHOs or randomly calling the pregnant women, whether she's being followed up properly or not. So that is the mechanism that we have developed for the high-risk pregnancy, because Punjab is facing a load of maternal mortality, and we are bound and we really want to decrease that mortality. So tracking and diagnosing and following up of the high-risk pregnant women, I think it is the most effective thing that has to be implemented. Thank you.
Thank you, ma'am. My third question is pertinent to Dr. Padmaja. What is the new set of the challenges Telangana is facing in running the activities between first wave and second wave? Dr. Padmaja?
As Dr. Signa said, most of the challenges and the
question, Dr. Tamkeen and Dr. Inderpreet, please mute your mic. Yes, ma'am. Dr. Padmaja?
Most of the cases increased from first wave to second wave. So among them, pregnant women are also getting infected, and numbers increasing day by day. And then human resource problems, most of them are affected with COVID. And private hospitals, they are referring the cases in the last minute. And shortage of these test kits. And trace and give sufficient population, it is a big challenge. These are some of the challenges we are facing.
Ma'am, your voice is not audible. Okay, with this, we are now approaching to our last question. This is for Dr. Archana Mishra. What are the Dr. Padmaja? Yes, ma'am.
Can you hear me now?
Yes, ma'am. Now we can hear you.
Can I continue?
Yes, ma'am, you can.
So our major roadblocks are those increase in number of cases even among the pregnant women and human resource issues. Healthcare providers are getting infected, and at the same time, the ambulance drivers also getting infected due to COVID, and private hospitals are referring cases in last minute, and shortage of these testing kits, and to trace and give services to these migrant population is the big challenge which we are facing now. And most of the facilities, they don't have physicians to handle these cases, so they are referring these cases to higher center. Which, previously, we have identified Gandhi Hospital is the only one hospital for the whole state. But after facing all these problems, we have identified each district. We have identified one facility, and they are conducting these COVID deliveries. So mild cases they are handling, and moderate and severe cases they are sending it to this COVID care center at placed at Hyderabad.
Thank you, ma'am. You are requested to mute your mic. So now we are approaching to our last question, and this is for Dr. Archana Mishra. What are the roadblocks Madhya Pradesh is experiencing during planning out this activity to district level? Dr. Archana?
Thank you. Actually, the first challenge which we are facing at district level is since the number of COVID cases are high in our bigger district, the supervisor and the operator which has been engaged for our Suman call center have been put on COVID related tasks. So we have to call our civil surgeons and DPMs and tell them not to engage them in COVID related task of monitoring the COVID general patient. The second challenge which we are facing is regarding availability of space and near to maternity wing and SHU. So that one of the important objective of the Suman Help Desk is to facilitate the services of the women who are being referred from peripheral level delivery point. So this is also, and we have to talk one-to-one to the district administrators for facilitating their this thing, setting up of Suman Help Desk. And since we are establishing help desks at medical colleges also, and in Madhya Pradesh it's a separate department, medical education department. So a bit of interdepartmental coordination issue was there. We have addressed this by writing involving our Commissioner Medical Education, who is taking care of this, and we are trying to convince our gynecologists that they are there to support you. And your patients are coming in such a morbid state and you are not able to follow up with them, and also for the conditional cash transfer scheme, how we have to get the documents and all. So these are some of the, and also for the capacity building of the manpower hired for Suman Help Desk, we were not able to do on-site training. All the trainings were done online, so this has made some difference. So once this settles down, we'll be doing on-site training also.
Thank you, ma'am. You are requested to mute your mic. I would like to thank all the eminent speakers to spare their time and spare their valuable inputs. Forwarding this, coming to an end, I would like to call upon Dr. Padmini Kashyap for her closing remarks. Dr. Padmini, over to you, ma'am.
Thanks, Monica. So as we come to the end of this webinar, I would like to thank ASMD ma'am, DS RCH ma'am, senior officials from the ministry, subject matter experts, and esteemed audience for patient listening and enthusiastic participation. I would especially like to thank all the experts for their very informative presentation, which I feel must have addressed most of the concerns or queries coming from the field. Most of all, I would like to thank and appreciate my very dedicated and wonderful team at MS Division. We apologize for the technical glitches during this virtual webinar, but such things are ought to happen when events of such magnitude they are planned. So with this, I would like to close the session for today. Thank you so much.